Please go ahead.
Good. Okay.
So I was trained there, and I spent my time from 1966 to 1972, got my medical degree, then 1972 to 1975, I had my postgraduate degree, and I got my MD. Then I was teaching for about 2 years at the same place and also at KM Hospital for about 2 years. And then I decided to come to this country with the hope that I can do some research. But the things were changing dramatically, and all the requirements you need to get here was not a problem, but come here and get trained was a little bit of a difficulty. So finally, I got into the training program in University of Pennsylvania in Philadelphia in 1976. And I started my residency there, and I finished it in OBGYN, and I got my American college, American board's certification. So I'm an American board certified OBGYN, and then I started practicing. Initially, they asked me actually to join the teaching institution at UPenn, and I said no. Of course, I already had a daughter, so to raise the family, you need the money too. And I don't think teaching was that was enough for you to go on. So I decided to go into practice. So I decided to move to California because being from India, we thought weather over there may be same as India. So, and we already had a taste of heavy snow in Philadelphia. So we said, no, that's not where I want to go. So we decided to go to California. And I was in Los Angeles area, in San Fernando Valley, and I joined Kaiser Permanente. I'll give you very quickly in a few minutes a little bit of information about what is Kaiser Permanente and why I joined. But I joined Kaiser Permanente there, and I worked for about 2 years. But
Can you explain what Kaiser is all about?
Yeah, I will in a minute.
Right.
I just wanted to get a little bit info about me so they know who is talking to them. And so I joined there, and I practiced for about 2 years, and the situations were not so favorable due to the inflation in the country was about 18%. So everything was unaffordable. So I came back to a small town in West Virginia, and I did private practice for about 12 years. And then I left because my kids were growing up, and I wanted for them to get a better education, and West Virginia was not the best place. So I moved to Virginia, where I am now, in Northern Virginia, which is a suburb of Washington, D.C. And I've been there now, and I've been working here again with Kaiser Permanente, which I joined again on East Coast, and where I retired about 10 years ago from there after doing about 45 years of OBGYN. I thought that's good enough. Do something else, and that's where I am. So that's just a little short story about me. And now I will try to explain to you. So first and foremost, I'm not sure how much you know about the insurance system in this country, but the Kaiser Permanente is an organization which is, of course, called as HMO Group. HMO means Health Maintenance Organization. And in United States, if you know, then I'm sorry, but I'll just go over briefly. There are different ways the healthcare can be provided that you know about. So healthcare is provided, it all depends on different ways. So that there is a government and non-government way of getting medical care. The government, of course, provides you through their system of Medicaid and Medicare. And also there are other systems that government provides help. And that will be the Indian health system or Veteran Administration. And this is basically what the government provides you the healthcare with. Then you go to the other section, which is private healthcare, which basically starts with cash only, or you just fee for service, we call it, or insurance systems. And insurance systems are different. So you can have three basic insurance system in this country we have. One is pure private insurance that You go and buy all the insurance for your medical care from a company. Some of them, for example, like Aetna, Cigna, these are all private insurance companies that provide you insurance and you get your health care through them. And then there is organizations like Kaiser Permanente, which is Health Maintenance Organization, or HMO Group, which is a prepaid program where, the company that you work for pays for you and they provide the healthcare. And I'll give a little bit more detail why I work for Kaiser and what was the attraction for me. And that will help you to understand what is HMO system also. And then there is the last one is a PPO, which is preferred provider networks. And that's the third system that you can get into. So this is just overall a very basic description of healthcare in this country you can get at. There are other smaller sections, but these are the main sections that you may want to know. The Casa Permanente, or the HMO group that I work for, was started back many years ago by the Kaiser name. It comes from a person who was an industrialist and entrepreneur, and he owned a lot of industries that time, mainly mining and the industrial productions, manufacturing in California and Washington state area, west coast of United States. And he realized that that time the healthcare system was not so well organized or available as it is now. And a lot of people were not getting healthcare at all, especially people who were employees or people who were the lower resources in their hand were not getting good care. So he said, no, I'm going to do something about it. And luckily at that time, there was a doctor named Dr. Garfield, Sidney Garfield, and he just graduated from medical school in Los Angeles, and he joined with Mr. Kaiser and came up with this plan that why not we provide this maintenance. Basically, all it says is there is a preventive care. And that way we can avoid people getting sick and hopefully they don't need any medical care. And that's the basic idea of their care was. So there are two basic points. One was to make sure that everyone is covered, whether you're rich, poor, whether you can afford, you cannot afford. As long as you're working for the company, they will provide you care. So they went to these companies and their corporations and says, listen, we are ready to provide you care for all your employees. Okay, you just pay me, X amount of dollar for each patient, and we call capitated or per head. We will charge you so much money, and with all that money now, we will provide you every medical care they need, right from a simple examination to hospitalization, and everything will provide you. And they came up with a plan, and employees liked it because for them, it was great. They knew exactly how much it cost. Plus, every employee was going to be covered. So Mr. Kaiser, who was the industrialist, he agreed right away, with Dr. Garfield, and they started this small organization, and which evolved into Kaiser Permanente. And they have been doing same thing for many years now, almost 75 years or more. And it's the most successful healthcare organization in this country. And it provides about 12% of the population healthcare in this country. And they have headquarters, or their main quarters they have is in California, but they have 7 different regions in this country where they have individual corporations, which are all under the Kaiser Health Plan. So Kaiser Health Plan is divided into 3 parts. One is the main Kaiser Health Plan, which is the parent organization. And then there is individual organizations, like we are in Mid-Atlantic states, so we call Mid-Atlantic Kaiser Permanente, and that provides all the healthcare in this area. So they have 3 components. One is the administrative, which is a organization, which is Kaiser Permanente, and then there is one they call Kaiser Health Plan. which is the insurance products that they provide. And what they did was the best part of it was that Kaiser Health Plan is non-profit. So in this country, you make money and you decide how you're going to spend. In non-profit, you don't keep the profits. You put it back into the organizations working and maintain that organizations. And the government, of course, there are benefits in taxations and everything, but that's the non-profit organization part of Kaiser Permanente. So they don't make any penny profit. What they do is, for example, to give you an example, they will go to Amazon and said, we are ready to provide you healthcare for your 10,000 employees or 100,000 employees. You just give us this money, and Kaiser will take that money, and they made a contract. So physicians group that I work is Permanente Medical Group, which is not really a non-profit. It is a for-profit organization. So what they did was the Kaiser Permanente came back and says to Permanente Medical Group, you are independent organizations, but we have a unique contract with you where we pay you for each patient you take care, X amount of dollar, and you take care of that money and give it to your doctors in the way you want it, and you are allowed to make profit if you want to with that money. So what they will do is, for example, if they got a $1 from Amazon, they will give Permanente medical doctors 30 cents or whatever. And then they say, so 30 cents taken by the Permanente Medical Group as at individual organizations, they will go out and hire as many physicians as they need, but their job is to make sure that all the medical care is provided to all the Kaiser patients who have Kaiser Health Insurance. And that's how it works. And the advantage was that the doctors can practice independently. Kaiser doesn't tell them how to practice. They just give them guidelines and says, we want these qualities to be provided, that all patients must be happy. So the satisfaction should be good. Then you must meet a lot of criteria. Like, for example, in my department, we made sure that, because remember the basic principle of Kaiser was to preventive care. So they want to provide each and every patient, for example, a pap smear. Make sure that every patient gets the pap smear done. And that's my job as a doctor in Permanente Medical Group, to come up with the whole system that I provide a clear-cut, care for providing pap smears, so that I find the patients as early as possible, prevent them from getting cancer. And even if they get cancer, then I treat them very early stage, and I prevent a lot of patients' sufferings, and at the same time, save a lot of money for Kaiser Permanente too, because less complications, less money Kaiser has to spend. And that's what the contract is made of. But Permanente medical doctors will make a contract with physicians and said, okay, you come and work here, and we'll provide you fixed salary, and we'll provide you all the help you need. That means I go to my office every day from 8 to 5 to do my work. And I don't have to worry about whether patients will, I don't need to go and market my product or anything like that, like private practitioners has to do. Here, I just go there and they have a ready-made schedule for me from 8 to 5, whatever, 25, 30 patients a day they give you, you just take care of them. And at the end of the day, you go home. And if you're not on call, you're free. So the lifestyle was much, much superior. And I don't have to worry after 5 p.m. because there will be doctors on call who will take care of all the patients who are part of the Kaiser Health system at that time. So this is a system which was so nice. Here, the best part is that some people, the problem with the medical care occasionally is that in private practice and HMO group practice is that incentives are taken away. So for me, when I go to the office, everything I provide is exactly what I think, based on my knowledge and my understanding and my training, what is the best for my patients. I don't have to worry to whether I need to do a surgery or not do surgery or do this or not do that, because there is no incentive for me. I don't have to worry about the expense part of it. I just do what is good for my patients. So that really was very attractive to me when I came out, because I didn't want to get into this competitive field where you have to really compete hard and do all kinds of things, marketing and whatnot. And I thought at the end of the day, I'm very happy providing this kind of care to my patients. And it did work out very well that you can give best care to the patient. So that's just the basics of HMO group practices. Now, there are many questions you may have, and you're most welcome to ask any questions regarding anything about healthcare in general. Okay, so go ahead. And you can ask me questions about my training and anything else you have in mind. You're welcome to ask that too. I will try to help you any way I can.
Don't be shy. This is a rare opportunity. You were at IMG, correct?
Yes, I am an international medical graduate.
Right.
Yes,
all of you are IMGs, okay? Good.
Yes, we are all IMGs, and I did take my license exams like you do. Exactly same, everything same. Yes, no change. It's just that you choose what you want in life along the way. And I've been one of the most happiest person in the country, I would say. had a great life and lovely. I mean, I had many patients, many kinds of patients. I had exposure to all lives, all kinds of life in this country, all cultures, all kinds of people. It was just one of the best of both the world, you can say, that I had. And I'm most satisfied, one of the most satisfied physicians. I do go out and give sometimes a talk about retirement to some of the physicians in Kaiser also, and tell them, they call me sometime and said, why don't you come and talk about your experience in retirement? And I tell them that it's one of the best places to work and it's one of the best systems in the world. Of course, nothing is perfect. Even Kaiser has some problems, of course. There are some restrictions that comes with you because you are not the boss always. I mean, you are still a boss on your own, but you are not the boss, because organization will have a structure which will guide you how best to perform your duties so that we provide care at an affordable price, but still give the best quality care that you can provide. And so there are some restrictions that come with it. And, but, nothing is, 100% in any system at any time. So.
We have two people online from India right now, at least. Yeah.
I see Dr. Nanavati and Dr. Madhu Jatti. Jatti, right?
Yes. I'm from Andhra Pradesh, Hyderabad.
Oh, you are in Hyderabad.
Yes.
Wow. Nice.
I'm actually from Bombay as well. So.
Oh, you are from Bombay? Where are you, Dr. Nanavati?
So currently, where as in South Bombay.
South Bombay. So yeah. I'm Gujarati like he is. I know he's Gujarati. From the name we know we are all. So that's just part of our different cultures in India, right? So you guys have any questions? Don't feel
yes,
shy.
Dr. Tarun. Oh, please.
Sorry, go ahead.
Yeah, Dr. Tarun, I was wondering if Kaiser is like a private multi-specialty hospital, or do you have your own office and then they'll just send patients to you?
No, I mean, not like that. So we have, in most of the places, we own our own hospitals too. We have our own hospital system, but not everywhere. Like where I am in Virginia, hospital business is the not most profitable business for healthcare industry anytime. Most of the hospitals don't really make money, but Kaiser still had is, like California, we have a number of hospitals that we own, but in Mid-Atlantic, where I am, we don't own the hospital. But what we do is we make a contract with a larger hospital group, like Virginia Hospital Center in Arlington is where we have a contract with, or we have a contract with Reston Hospital in Reston. and we have a contract in Woodbridge areas too. So we make a contract with the hospital that I will bring all my patients to you, and we sort of develop a contract with them that for X patient we'll pay you so much. So we set the price, we control the cost, and we work with them. But then we make sure that all of our patients only go to that hospital, because we don't have a contract with other hospital. For example, Innova Fairfax Hospital, we don't have a contract. So what will happen is that if patients unknowingly or some reason goes there, they can charge whatever they want. Because we don't have a contract or agreement with them, how much we pay them for normal delivery or a cesarean section or appendectomy or whatever they come to emergency room. Innova can charge us anything they want. So we don't prefer that. But we prefer you to go to only contracted places that we have, because we have to control the cost too. I cannot provide you care at $1,000 per person per year when everybody else is charging $10,000. The only way I can provide $1,000 per person per year is if I control my cost in a methodical way or a smart way, and at the same time still provide a very good health care that you can provide.
So the doctors from Kaiser go and work in the hospitals that Kaiser is contracted with?
Absolutely.
Or the doctors are from the same contracted hospital?
Yes, no, Kaiser doctors work in the hospital like any other private doctors goes to work, right? So it's just that they're working for Kaiser.
Oh.
That's all. Right.
So you only see the Kaiser patient?
Yes, only Kaiser patients, yes. I mean, some hospitals will make a rule that if I want an attachment as an attending in this hospital, they will say, oh, you have to also take care of some emergency walk-in patients when it comes to the hospital sometime. But it's a unique contract that we make, and we only see Kaiser patients. That's our main purpose there, right? We don't see any other patients. I cannot even see if I want to. So if somebody comes with no Kaiser insurance, I cannot see them as a doctor, because remember, malpractice insurance is a very important part of healthcare. And Kaiser covers my health insurance through them only for me doing work for Kaiser patients. If I go out and do some other patient's practice, I'm responsible for my own, insurance at that time. So we only see Kaiser patients. Yes.
Does these rules work even in cases of emergency? I mean, some cases, emergency cases?
I didn't get your question. Sorry.
In the emergency cases,
Uh-huh.
I mean, should you stick on to Kaiser patients even if maybe some
Yes.
other patient comes in emergency for some
Yes,
other
because
insurance company?
yes, correct. You are very correct. Good questions. That's the reason why we make a contract with the hospital, that my doctor who comes to work here will only work for Kaiser. They will not work for other patients. On humanitarian basis, yes, if I'm in ER looking at my Kaiser patient, and if some other patient comes and they really need somebody instantly, whatever reason, then yes, as a doctor, I will do my duty. But that will fall under the category of what we call Good Samaritan law in this country, which is where you're not liable for providing care in emergency to any patient in the country. Okay, that's just we do. But most, like if by choice, I will not go and take care of emergency patient if it is not a Kaiser patient, or if I'm not asked or forced to do that, I will not do it. Correct.
But Kaiser has a rule that you can go to any hospital. If it's an emergency, you go to the closest hospital.
Yes.
Right? Yes.
Yeah, that's the rule of the 911 system. They cannot take you anywhere you want. So if I call a 911, right, then 911 will decide where to take me nearest based on your medical condition, right? They will not ask you, oh, if I say I don't want to go to Western Hospital because I don't like it, take me to Fairfax Hospital. No, 911 cannot listen to you, and they will not. That's independent organization that makes the decision based on patient need rather than where patient wants to go. So that's how it works. I cannot just That's why they give you a call center number and all that. Kaiser gives you a facility where you call if you start having problem, and they will tell you if it's an emergency, just call 911 and take care, and Kaiser will go from there. But if it's not an emergency, then they want you to call Kaiser Health System on-call services. They will guide you where to go, where they'll give you appointments, and whatever else you need that time. They'll take care of you because we have doctors and nurses on call that they guide you where to go. Right.
So at the same time, there are quite a few people who, like as you mentioned, you pursued your MD in Bombay, and then you went to US for your specialization. So do you think that any people who apply for match in the US who have completed their MDs, do you think that affects the chances of a person who's not directly going for residency, like who's not done MD, most people who directly go there to start their MD in the US, do you think the chances of them getting matched are lower just if they are pitted with people who've pursued MD and then are going there?
Okay.
Does it
So if
help?
I understand your question is qualifications of India necessary, and whether it helps you to get into a matching program? Because of that, no. When I applied for my residency program, they didn't really care whether I had MD or not MD. If I was MBBS, I would be same. So I was competing with all other people who came from medical school with MBBS only. Only thing it matters is that when you go for an interview and when you meet a professor, that interviews you, they know because they have a choice, right? See, the matching basically means they are choosing you and you are choosing them, right? That's the matching program. So when they choose you, they are not only going to look and see whether you had your medical degree, where from and all that, but also they want to know how much you know. But if they find out that you're already trained and whatnot, then some program may want to have somebody like you, then you get a little preference. But does it really make a huge difference? Not really. It didn't make a big difference in my getting into medical or a residency program. No, it didn't make any difference, really speaking.
No, so what I meant was that it doesn't affect people's chances who have not done MD in their home country.
No,
it's not that
it
if you are with a guy
doesn't
like
affect
this,
at
you
all.
won't be taken. It's not like
No, it doesn't matter. So if you don't do MD in India and come here, no problem. It doesn't matter. No, you just come here and apply. All they need is basic requirement for the residency program, which is that you are a foreign medical graduate, you have done your ECFMG, and you have passed your exams, entry exams, before they give you into residency program. And no, it doesn't matter. No, not really.
Well, currently, I believe that you have to do some observerships in America and get letters of recommendation. No matter how good you are, you still have to go through the whole process separately from American graduates. American graduates go right away, but foreign graduates have to have this other program of like what we're doing right now.
Yes,
Yeah.
yes, correct. Yeah, there are many programs. You want to qualify to get into any program, you have to do the observership. Because they want you to get acquainted with medical system, medical terminology, medical words, diseases. They are different from different part of the world. When I came from India, I had no idea what is Coxsackie disease because I have never seen one. I never heard one. Okay, it was only in my textbook that I read. But here in this country, you have to know. So Lyme disease, simple examples I'm giving you. You're not going to. So it's good to get into some kind of observership and go from there. And then you definitely increase your chance, and also you will feel more comfortable when you join the program, and you are more successful then.
at the same time, I had one. Sorry, I just had one question. So
Yeah.
most people talk about like malpractice lawsuits. Quite common. So how common are these issues? Assuming your practice goes well, is it that you still get sued irrespective, or is it like what are the main reasons of being sued? Is it misinformation or criminal negligence? What is the basis, or is it like every doctor gets sued at least once.
So the malpractice system, it was created originally for the patient's safety and more of a patient safety issues, right? So the malpractice insurance in this country, yes, it is a problem, but at the same time, it has also brought out good qualities of doctors. Patients are well taken care of in many different aspects of life, whether it is a quality of care or the providing care. So how difficult it is. So when I joined here, I didn't know nothing about you, just like you are asking questions. I had no idea what is a malpractice insurance, right? And I started working in New York in a hospital for 5 months. I had extra before my residency program. So I joined there, and good thing is that every hospital or every place you work, or whoever is the employer that you work for, will provide you your coverage for the malpractice. And they take care of all that. So you don't need to worry. It's just that you need to follow certain guidelines and rules that they will let you know that so many things you can do, so many things you cannot do, so many things you can talk, so many things you cannot talk about. And you learn all that along the way. I mean, I can tell you that it's a big rope that you have to climb in this country from the day one when you come till you retire, okay? It's never that you know everything about malpractice from day one. Now, you will learn along the way how to do safe practice, at the same time good practice. But that's one of the reasons that I made the decision, personal choice of working for Kaiser, was that one thing was for sure, that Kaiser has one of the very good malpractice coverage ever. And it is still, because they're self-insured. So the way malpractice insurance works is that you go out and buy malpractice insurance from a company that said, okay, for X $1,000 you pay me every year, I'll take care of all your needs for malpractice, including providing your lawyer, going to the court, whatever settlement, and anything we'll take care of, right? So Kaiser does the same thing. But if you are in a private practice, for example, and I go buy my own insurance, right, the premium can keep on rising based on market and also your individual performance. Because if you start having 2 and 3 and 4 malpractice cases a year, then they're going to figure it out whether you are a high-risk doctor or you are a low-risk doctor from their business perspective. But good thing about Kaiser that I worked, or HMO group that I worked, was that they are self-insured. That means that they have their own insurance funds. They don't buy insurance from anybody. I mean, the last time I heard was that they had $14 billion in funds they have to fight any malpractice case that anybody brings to Kaiser. So one good thing was that you never have to worry. And one of the things that I made decision to work for Kaiser was that compared to other private practices was that I want to work where I don't have to think about malpractice. I want to do just independent good practice from my heart, that I know what is good for my patients and not worry about it. If I get sued, fine, Kaiser will take care of me, okay? And that's what really gives you such a great comfort when you go to practice in life. Because I know many people who do private practice, they have to do so many things. And also the premiums keeps on rising, and that adds to your cost when you do private practice. And simple mathematics of life teaches you that if your cost goes up in life, you try to create more money, otherwise you can survive, right? So that's where the problem comes.
What is the average malpractice insurance for OBGYN right now, privately?
Based on the areas, of course, it changes in different areas, like high risk areas like California or New York City or major metropolitan area cities, very high risk there. But if you go to small town, the risk is smaller. But I started with malpractice insurance in OBGYN when I started with Kaiser back in California. At that time, it was about $15,000 a year that Kaiser will take care of it. But by the time when I was in private practice in West Virginia, I was paying $74,000 a year.
74,000.
Yeah, right. So if you just do simple math, it's like more or less 1/3 of your cost of practicing. Okay, because rest 1/3 will go into your practice taxations and all that, and 1/3 you bring home. So we call it a dollar value of practicing. So the dollar value of practicing means that every dollar I get or I earn when I do practice, right, I have to spend 35 cents per dollar for my practice itself, providing facilities, people, and whatnot. Right? 35 cents you provide for malpractice insurance and taxes, and then 35 cents you take home, right? So we used to say the dollar value of a practice basically means that if you make less than 50 cents a dollar, it's not worth practicing because you are really paying more to other people than yourself. So, and that equation is still worse. Right now, some areas, OBGYN malpractices are highest in some part of the country, like California or New York. They are close to $140,000 a year. So you have to think that that's a problem, but I always felt in my life, whether I was in private practice or ever, I never cared whether somebody sues me or not. I just do my good practice with my good heart and your knowledge, you just put your best effort in. Because if you keep on worrying about malpractice when you practice, then you cannot do a healthy, nice practice for your patients. You just do practice and go on. And I know one thing for sure that really helped me, and I never have to worry, and you don't get sued. You do well on your own. So that fear has not to be there. Let not that fear control your life or a practice when you come or when you practice in America. No, you shouldn't do that at all. No. You just be aware of it, but don't need to worry about it.
Yeah, first off, good morning, Dr. Dharia.
Yes.
My name is Katerina Agenda. I'm from Germany, a recent medical graduate. And I was wondering, do you have any recommendations or tips for our residency application as an IMG, and especially for the residency interviews?
So my experience, I'll base it on my experience, my answer. Okay. So I get a call from so many Indian doctors who come to this country, right? And they all want to get in the residency program. And I know it's the hardest thing. I can guarantee you on a competition level, if you put, then you are really on the bottom part of the competition, period. Whether you like it or not, no matter what you say, it doesn't matter. You are, okay, for a variety of reasons, okay? There are all kinds of reasons that we know that you will be at the back bench of the class, period. So how do I make my chances better? What do I do to get better? So what I have been trying to suggest to people who have come to me and asked me that question is that that always remember that major medical schools like big hospital centers, don't even aim for it. Don't go there, okay? Your chance is almost zero. Let's put it that way, okay? But there are a lot more people competing for the same spot that you are competing, right? So where is your best chance? So in this country, there are needs in smaller towns or smaller hospitals, right? So what is your best chance? The best chance is in a smaller program. Smaller means a city with smaller population, smaller medical school. Don't worry about it because that's the best place to get into the program. For example, I had sent a number of doctors who had called me to go to places like, for example, I just give you an example that there is a university called Marshall University in West Virginia, in Huntington, West Virginia, right? So now that's a smaller program, okay? And they have a harder time getting residents sometimes. Okay? So that's one way to always think that when you look for it, don't aim for the highest program. You can try, but you don't expect that you'll get it. Instead, your chances increase by going to smaller programs. The trick is that you go into smaller programs, and then within a year or two, once you got your qualifications, the qualifications in this country for you to move up is that you have experience because you're coming from other part of the world, right? So a lot of issues for people who want to hire you as a resident also, right? They have to do a lot of training for you. Instead, if they find out, oh, you're a well-American trained, you had to go to university in America and you got trained, you can jump the hoop much, much faster. Okay, so I would try for a smaller universities, and within a year or two, have yourself transferred to residency program, other place. Even if you end up losing 1 year, say you have to repeat 1 year, fine. But now you got into the program at the cost of 1 year of your life, but you got into the program that you wanted to go without any other difficulty. So that's what I would try, is smaller programs. So look at the programs which are smaller towns, smaller hospitals, rural areas. You have a much better chance to get in there rather than any other place over here. And also there is one other thing was that if you have a visa issues or something, there are some smaller towns, hospitals and programs that they will hire you. And if you work there for 1 or 2 years, it's much easier for you to go up from there. But residency program, smaller the programs, better off you are. Is it the best suggestion I'm giving you? No, I want you to go to the best universities, Harvards and Stanfords and all that. But not easy to get in, right? So how do you get in? Well, you try to get in smartly, get into smaller program, and then jump the hoops. And if you end up sacrificing 1 or 2 years of your life, don't think too much about it. Remember, you have to, at a small sacrifice, small cost, you are getting career that you wanted to start with. So that's what I would do. I hope I answered your question.
Yeah, you did. Thank you.
Okay.
Good morning, Dr. Dharia.
Good morning.
Good morning. My name is Apurva. I'm an IMG from Australia. And I wanted to thank you this morning for talking about the insurance and giving us such an excellent summary. And also, I had some questions regarding HMO organizations. Does this mean that they focus a lot more on preventative care?
Yes, absolutely. It is like, let's put it this way. So let me give you other way example, how it works and how it is impressive. For example, like, so the doctors group that I told you about, permanent medical group doctor, they are for profit, right? So what happened is that, yes, I have an incentive to do better preventive care. So what they do is they established like 10 items every year or 15 items every year and said, okay, you are practicing in this group now. And so what is your pap smear rate? What is your mammography screening rate? How many patients you bring them back for proper diabetic care? How many patients hemoglobin A1C you got into control with your practice and your, whatever you did. So each individual is judged based on quality of care that you provide, right? So we have quality measures, and some of the quality measures are totally based on preventive care, like mammographies and pap smears and colonoscopies. And so if you have, let's say, for example, so what they will do is, so if I had, let's say, 100 physicians in my group, right? So they'll draw a graph and said, okay, if you fall over the 90th percentile, you will get the bonus. Otherwise, you won't get the bonus. Okay. So for that, who doesn't want to work hard for it, right? So I get extra $10,000, $20,000 every year, in addition to my nice salary that I get, right? So that's the work. So they are really working very hard to provide quality of care and also for preventive care. And yes, I think we are the world leaders, I said, as a health insurance company in the country. Of course, United States, I think we rank very high. There are 2 other programs which rank very high, like Kaiser, that the government of United States through Medicare system decides where you stand with, you are providing all this preventive care, quality of care that you provide. So there are quality measures based, and they are decided by the government and by organizations. And they base you on that, and they judge you based on that too.
Okay.
And that you can use it in your advertisements if you want to sell your product.
Mhm.
Yes, so it is very highly primitive care services. And yes, you work hard, no question. Yes.
Mhm.
When you work hard. Remember,
Yeah.
you're not the boss. They tell you how many patients you want to see a day. Right? In private practice, you can decide, no, today my daughter has some program, I need to go. Sorry, you may not get that chance in Kaiser.
Okay.
But
And also, Dr. Dharia, one more question regarding
yes,
residency. So I did hear that there are such programs called transitional year programs where they give you 1 year of residency. Would you say that that's another option we can go for or not?
well, I'm not so sure about 1 year program, but if it leads to a better opportunity, yes, I would do, because if you don't have any choice to start with, right, then I would take that choice. Absolutely. Because very important for you to understand that you all, let me compare it with different things. Maybe that will impress you more. So when I came to this country, right, okay, I wanted to buy a car, right? In Philadelphia, when I started residency, I had a daughter. I went to get a car, and the car guy says, sorry, you can't buy a car. I said, why? He said, you don't have a credit in this country. I said, I don't have a credit? What do you mean by I'm a credit worthy guy? I'm giving you money. What's the problem? He said, no, you have to have a credit. I said, what do I do for a credit? He said, you go get a credit card, whether you need it or not, you get a credit card, and then you start paying back in timely manner your credit card balances, right? Once you do that for 1 year, you will get into a recognized system which says, yes, you are a credit worthy, right? So that's how I got my first car after 1 year of waiting. Same thing here. If you start working in institutions, which is a teaching institution, whether it's for 1 year, 6 months, whatever, right? Remember, it adds to your profile. So if I don't have a choice, I would work 1 year, Yes, it will probably involve some cost and your sacrifice of your time, but it's worth it. And don't think, how can I go into Alaska and work in a small town? Don't think that. Remember, you will have to pay a small sacrifice now for better life in future. So, yes. Does it answer your question?
Yes, it does. Thank you, Dr. Dharia.
You're welcome. Sure.
What you just said.
Oh, go ahead, please.
Oh, sorry.
No, go ahead.
Yeah, what you just said, Dr. Kumar. I think it's a preliminary year, right? The usually in general surgery.
That's right. I've heard transitional as well. That's another name for it.
So I'm not sure. I don't know if you know this, but I heard that sometimes you do this year, and after that you have to completely apply for residency anew, like from the start, and that a lot of people don't get a spot after that. I'm not sure why, but do you know is it like the first time you apply for residency? Do you have to get the ECFMG certificate and everything, or can you just apply after that 1 year, like let's say an American student? So I'm not sure about it, but
I believe that if you applied for the first year, then you would have had to have your ECFMG certificate anyway for that program, even if it was just only 1 year. And then afterwards, I do understand you do need to apply again for residency and complete 1 year after, like for their requirements. But I feel like I'm looking for a foot in the door, basically.
Yeah.
So
it's better than
even
nothing, certainly.
if it's better than nothing, and I'm ready to look at any options. So
yeah.
If it's Alaska or
this foot in the door reminds me of one more thing that I have always told people, that there are some residency programs. It will be very hard for medical graduates in this country, like ophthalmology, ENT. You're not going to get in that quickly. Trust my judgment, because the boards that controls these residency programs, they are super cautious about access and all that. So they don't want to create so many spots just because there are many people applying for it. As a matter of fact, they want to really control how many ENT surgeons they want in this country and how many ophthalmologists they want in this country. So be realistic with your expectations when you go for residency. You can aim as high as you want, but at the same time, be realistic. Otherwise, you are really reducing your chance of getting into anything. Instead, if you have to do general surgery for 2 years, do general surgery for 2 years. But then if that helps you to get into ENT, good enough. Now you have a better chance than not going to general surgery and going straight for ENT. You will never get in because these people control the entry door quite a bit. And it is still now. When I came, it was there. And it is still now, whether you like it or not. That's just the way system works.
Good morning, Dr. Dharia.
Yes.
My name is Manisha. I'm also from India. I was born and raised in New Delhi. I graduated from Dharia Medical College. Thank you so much for taking the time to speak to us today.
No problem.
I was hoping to understand a little more about the HCA organizations and how do they differ from HMOs like Kaiser. I've read a lot about HCA residencies and they offer residency positions for medical graduates, but I don't know a lot about it.
HC.
You're talking about which organization? I didn't get that.
HCAs. HCA.
No,
I don't know.
So there is one thing I know that there are medical colleges, like overseas colleges, right? So they provide the medical training there, and then they try to get you into residency program here. And they do some universities like NYU and others had made contacts with these, foreign, they call it, or outside United States universities where they have programs that they get in and you go there, work for 2 years in Bahamas or wherever, and then they come back and they get you. But whatever I have heard so far has been that that is the most difficult way to get in because you still have a lot of difficulties with that. Because after 1 year, it's not that easy to get into regularly residency program. So I'm not very, very sure that's the best way to go. Like in India, people go to Ukraine to get a medical school education and came back and they have a hard time getting residency programs in India right now. Nobody can get in. They can't even get a license. Okay. So that's my understanding. I'm not so sure I know about this particular program you are talking about. Sorry.
That's okay. From what I know is HCA is a for-profit organization. And
HCA, you talking about? HCA?
That's right, HCAs.
HCA.
Okay, I'm not saying that. HCA, sorry.
They don't have residencies, do they? I used to work for them.
Okay, on Residency Explorer, it's a tool from where we can find residency positions. They have an ACGME code, you can apply to them. They do offer residency positions, from what I know, what I saw on Residency Explorer.
I'm not aware of that. One thing you should know is Kaiser actually has a medical school. It started a medical school a few years ago.
And they have a residency program too, Marty.
Yeah. The other thing you just need to know is Kaiser has the most incredible electronic medical record system or medical system. It's everything you do is everything is online, basically. You can go to any hospital around the country and your record comes right up. It's amazing. It's probably the best electronic medical system. They spent billions of dollars and it's incredible.
Yeah. So to impress you more with that idea that when I practice here in Virginia area in Kaiser as an OBGYN, I had several patients where they were patients from Africa, Ethiopia, and India, right? So I used to manage my patients in India. Like I have an OB patient who was like 26 weeks and wanted to go to India for 4 weeks and come back. Because, we have this tradition of, goat bharai and, baby shower. So they want to do that in India and then come back. So they will all ask me and said, how I'm going to go there and stay there 2 months. Can I go and how would I do it? I said, well, first you'll have to get an OBGYN over there just for emergency and whatever things you need, but we can work together. The good thing was that everything, the medical records are all 100% on digital format, period. We don't have any paper. I didn't even have prescription pad in my office. I don't have prescription pad. I have to request one. If somebody says, I want a prescription to go and fill it up in Walmart pharmacy, which you are not, that you pay from your pocket. But he said, I want that prescription. I had to ask somebody, my nurse, and said, please give me a prescription to write on, because I don't have one. It's all electronic format. So I used to manage patients in India electronically, in the sense that they will go over there and provide me, I'll give them set of numbers that I want, over there when they go there, and they'll communicate with me through the, computers over there. And at the same time, doctor over there can see her records on computer also, because patient have access to their medical records. So she managed her 2 months of pregnancy over there. And then she came back and I had all the records, what she did over there. And it's like nothing happened. And it was such a great experience people have with electronic medical records that you can literally practice anywhere in the world. I can do all emergency things even there too. If somebody develops emergency, I can provide all the records and information they need to take care of the patient over there. So yes, Kaiser is one of the leaders in this country in electronic medical records. Even before President Obama came back and started, actually President Obama took examples of our system and tried to introduce in this country. And he did successfully quite a bit of electronic medical records that you see in this country right
now. Dr. Dharia, I had another question.
Yes.
I know this is way down the road, but when we're looking for a position like you're working at Kaiser, does the reputation of the residency program or of the medical school you graduated from matter when you're looking for a position later on?
Yeah, so yes, it will matter, because I was chief of OBGYN in Northern Virginia, and I used to have 60 doctors work for me, right? So I always have a need for a doctor to hire. And I used to hire people, okay, at that time to work for Kaiser. And so to put it in a simple way, do I only look at and say, oh, he's from Harvard, that means he's the best, I don't need to look anywhere else? No, that's the wrong way to judge a person. Instead, there are several things goes into equation when you choose a person to work for you, right? If I'm going to choose you as a resident or as a attending, I'm going to look at everything that, that I can find out about you, what kind of person you are, what kind of character you are, and what's your attitude, and all that. So I had a doctor that applied, and she had a great training in Mayo Clinic, right? So Mayo Clinic, very big name, right? Medical school from there. And when we interviewed her, we normally have 3 people we interview together. One of the things that came out was total arrogance from her that, hey, what we do is the best. And she started telling all of us that what we do in Kaiser is wrong. And she wants to join and change everything. So you already know, wait a minute, I'm hiring you or you are hiring me? That's the question we had. So it doesn't matter if you are from Mayo Clinic or what program you had. Everything else matters too. But definitely, if I have 2 candidates who are equally good in every aspect, and one person had a training in a smaller program, which I'm not so fully aware of, and then one who had a well-trained program, then yes, of course, it will come in the picture too. It's not totally ignored, but it's not the only thing that you look for in your attitude, your manners. A lot of things matters. Yes.
Does that mean that Kaiser has a very widespread system across the US?
Yes.
So is it available everywhere?
No.
Oh yeah, I mean, no, not everywhere. No, we 50 states, and we don't have, in every state, we don't have presence. No. We have 7 regions, which probably will cover about 13 states, but not 50 states. No, because we don't have I mean, to expand a program like that, you need resources and all kinds of things you need to expand.
And do you have any recommendations as how to prepare for the residency interviews? Is it worth it to book a professional interview training program, or should we just spontaneously go ahead?
Right. No, you're right. I'm sure. Yeah. I'm not aware of any professional programs that does prepare you for interview for a residency program. I'm not aware of it. If it is there, I don't know about it. And but would it help you? Well, it cannot hurt you. You are more prepared because a person who is teaching you is aware of a lot of things about programs, or somebody has been like recruiter or a program director for a long time, and he now comes up and says, okay, I want to give you some tips and hints that may help you to get in easily, of course. But I think that number of things that I think people decide in residency program is one, how many people apply and how many of them have equal qualifications, and then they take into question the personal characters and all those things come. So I'm not very fully familiar, but if I was applying for a residency program, one, I think if you go with two things. One, present yourself the way you want to present yourself. Don't present yourself the way somebody else wants you to present. No, that's not going to help you, because you're going to make a lot of mistakes along the way. Instead, just do what you think is the right thing. And two, remember, I give you an example of the doctor who came from Mayo Clinic. Any kind of arrogance should be off the table right away. Okay, period. I mean, I believe that compassionate, mellow, listening attitude probably will be more useful characters when you go for a residency program. You try to listen to them more rather than give them a lecture, and be to the point. I mean, remember, every extra sentence you speak, they're judging you from that too. So be careful there, and but at the same time, be just yourself, what you want to be. Don't just go there with the fear. No, I mean, at the same time, take away the arrogance. Just think as if you are applying for a job. You want to be honest, upfront, and compassionate. Very important word, compassionate. Remember that mellowness and compassion will come across very quickly. Okay.
Yeah, they're not looking. They're not looking at this point. They don't care what you know. If they ask me, they want to know who you are, and do we want you to work with us for 3 years? What kind of a person are you? And that has to come out in the interview. You have to change gears. It's not an examination of how much you know about OBGYN. Is who are you? Do we like you? Can you work with us? Are you friendly? Do we want to be with you for 3 years? That's the interview. And as Tarun says, you have to be yourself.
Yeah. I give you examples. I went for an interview for a residency program in Chicago when I came, right? An OBGYN program that I applied for. I mean, I already had a training. I had a good training, and I was teaching actually residents over there in India. So when I came to this country, right, if I project them as, oh, I'm already trained and I don't need anything from you guys, just take me in so that I can complete and go out. No, not interested. No way. So I went to meet this professor, and I know him because I have seen his work before. He has done a lot of pioneer work in laparoscopy. Okay, and I had also had some basic training in needle scopy back in India, because we had a lot of miliary tuberculosis in abdomen. And I had a professor that I worked with who used to do just simple needle laparoscopy. Just simply put a needle in the belly and look for these nodules and take a biopsy and done with it. So I knew this, right? So I didn't want to go and boast myself. I know exactly that time why I don't want to prove it to him, because any kind of arrogance that you try to bring in is going to hurt you. So that's not necessary at all. You don't need to show off also too much either. So when the professor started asking me are you aware of this laparoscopy? And we had already laparoscopy in India, and he had it probably 3 years ahead of us, but we had it where I worked in KEM hospital. We used to do laparoscopic ectopic pregnancy already before I came to this country. So he asked me, so when he started, I wanted him to ask me rather than tell him what I know. Okay. I didn't want to talk that way because I don't know how arrogant it will come through. So you just be careful when you talk. Okay. Doesn't mean you want to hide at the same time. And then when we started talking, he started talking about his laparoscopy and all that. And I said, yes, I read your books and I read your articles, and you have done wonderful pioneering work, and I'm very impressed with your work. And that's one of the reasons I thought that I maybe, if I get in here, I'll be very happy to work with you. And then he asked me automatically, he said, have you had any experience? So then he asked me. So I listened. And that's when I said, yes, I had some, but not like you, but I had some basic training programs. So you see, use the words mellow. You see, use the word mellow per word here. So put your words properly. And you say, not like you, you are better than I am, but I also have some training program. So you are indirectly conveying to him that, hey, I'm also a little experienced here and I want you to know who I am. But yeah, there are ways you can talk, and that's what you have to just do. And if that's what that guy teaches you, the training, you were talking about that person that teaches you how to do the residence interview, then it's fine. Go to that program. But otherwise, just be yourself, that how I want to present myself to this person, and that's very important. So just keep that in mind when you go there. Okay. Nobody needs to know how much you know. They just want to know who you are as a person, how you come across as a person. That is very important. At the same time, you don't want to give up an opportunity to tell. So then I started talking about needle copy that he never heard about. So then he liked it very much. And of course, he put me on a higher list of his choice in matching program, but I didn't want to go there anyway at the end of the day. So anyway, I hope whatever I'm saying helps you to understand when you go.
It does very much so. Thank you.
Any more questions?
Sure.
You can talk all day if you want. This is plenty of time. Really.
Very happy to help you and very glad. And all of you, best of luck to in your life. And if anytime you want me to help you with something that I can help, please let me know. Marty is my good friend, and Dr. Stein can always guide you towards my direction if I can be any help. Okay.
Great.
All right.
Thank you.
Good
so
luck
much.
to all of
Thank
you. Okay, Marty. Take
Okay.
care.
See you.
Thank
see
you.
soon. Okay.
Thank
All
you,
right.
Dr. Dharia.
Thank you.
You're welcome. Bye-bye.
Bye.
Get out of here. Okay.
That was great, actually.
Great.
Yeah, that was
Yeah.
really good.
This is a very special doctor, but he gives you great advice.
Especially when it comes from an IMG, they understand issues that maybe are more IMG faced. So obviously you get a bird's eye view of someone who's an IMG and has also understood the American system. So it was quite helpful.
Mhm.
Yeah, especially since I don't know if my fellow colleagues feel the same way, but I don't really know any other people from Germany who want to go to residency in the United States. So there's really nobody to talk to share the information one has. So obviously the only source is the internet. And I feel the more I Google, the more frustrated I get sometimes. So it's really nice to have somebody to ask questions.
I'm in the same boat as you, Karen. Like nobody I know from Australia has ever tried for a residency in the US. So this is really the avenue I have. It's through observerships and internet, but observerships is better.
Yeah.
How I found my mentor, and you might find this helpful, is that if you go on Twitter and you use certain hashtags, maybe you could find someone who was in a similar position Like, I don't know how it works completely. I'm new to it too, but I know that a lot of people put hashtags and then they can find their community, like maybe from Germany or maybe from Australia, doctors who have gone through the process, and then they reach out to you. They could respond to your tweet or DM you, and then you can find that way if you.
Oh, I never heard of it, but
I
it
will
sounds
ask-
helpful.
Well, I will ask him if it's okay to give him give you his email address. Okay, I'll check with that. He's a very generous man. I love him. He's wonderful. He's very smart. And so he's an IMG who ended up being in charge of the OBGYN for the entire area, having working 50 doctors working for him. So, you can make it. I think 1/3 of all American doctors are IMGs.
Yeah, I heard of it too. Yeah.
He and I think, made the same point that the best way to start would be in a rural area, not a big city. And you put your time in, and then you can transfer. But I mean, there are places that want doctors. So you can think about that.
Actually, I heard of a. I'm sorry.
Yes, go ahead.
I heard of a place in Kansas City that they had 4 residency spots for pathology, and they couldn't fill it, so they had no applicants apparently, or I don't know. But I was very surprised to hear it, because I mean, almost 50% of IMGs who apply won't get a job in the end.
Right.
So I was very surprised to hear that there are spots being unfilled in the end. Yeah.
Well,
Whereas Sir had mentioned that we could maybe apply to a lower, I mean, a rural program, and then midway, transition to a bigger hospital. So I had a query, like, could you leave midway, because won't it be considered as an incomplete residency? Because you're leaving midway, you're not completing it. So on what grounds could you transition to another, university? Unless the program has a transition or a preliminary year. If that's not the case for quite a few specialties, you don't have a transition or a preliminary year. So in those scenarios, how do you transition? Is it even allowed by the hospital?
I think he suggests you put your time in, and that you may have to spend a few extra years. I'm not sure it looks good if you start a program, then quit in the middle, because then the impression is, well, maybe you'll do the same thing to us. So you have to pay your dues.
Because it could come off as you mentioned, not sticking to a program. Like, even as you mentioned, they might think we could do it to their program as well. So that could maybe hamper chances.
I think you hear that he says every single thing about you is looked at in an interview. Your CV is looked at. How, have you, every year, have you been constantly involved in your program? I was listening to an interview by program directors that sometimes as soon as you walk on the property, you're being looked at. Okay. How you talk to a janitor, how you talk to anybody else, how polite you are. They always ask the secretary, what do you think of him? How do you behave? They have you interview with the chief resident, because you're going to be working with him most of the time. How do you get along? And everything has to be right. There's any tit of arrogance, or complaining about the hours, or the pay, and so forth, you're a troublemaker. We don't want troublemakers working with us.
And at the same time, as you are an AMG, so I just had a query on when you would be, say, hiring or interviewing IMGs, what would be going on in your mind as for criteria basis? Like, what would you see in an IMG as a US citizen?
A person. a person who cares about patients, a person who I say this basically that it's kind of like going on a date. Okay. And the second date is 3 years. So the really question is, in one interview, is this the person I want to be with? Doesn't mean we're not talking about, we're talking about your personality, your character, your ability to get along with people in the team, your sense of reliability, how other people look at you. Those are the issues. They're very different from everything else, every other test you've taken. And, some of you have had more formal kinds of experiences where you're not as maybe back and forth as a person. Here in the States, it's very different. People, and they very often they ask you unusual questions. What do you like to cook? How do you cook it? I mean, and that in the process, they'll still get a sense of who you are. So it's a very, very different, experience. And that's why you can't be phony. You have to be yourself. So the preparation, I don't agree with him doing these courses because the real issue is you.
So would you say it's more of a conversation then?
Yes.
Yeah, okay.
Yeah.
So it's not like a usual work interview where they ask you questions. How would you handle that situation? How would you handle this situation? It's more of getting to know you.
Well, the issue is, do I want to be with you for 3 years?
Mm-hmm.
And that has nothing to do with how you handle the situation. It's, do I want to be with you?
Yeah.
Will you fit into our team?
Yeah.
Actually, that sounds better. That it's a conversation than a usual interview, I think. But
Just like right now, we're talking to each other,
Yeah.
getting to know each other.
Mm-hmm.
Okay. That's what really, that's what it's all about. It's really it's a different kind of a match, it's a social match. And we see some very arrogant doctors who certainly wouldn't make it.
yeah, actually, I was scared because, as I think I told you about it, that my brother is applying in the United States too, not as a doctor, but in business sector. And he told me about a lot of his interviews he had, and there were a lot like personality tests and role plays, that kind of stuff. So I got a bit scared because I thought it's very stiff. One couldn't be oneself because it's so unnatural. But that sounds a lot better.
I don't think they do tests like that. It's there's some interesting studies I read that when hiring people, very often within the first minute, you know whether you're going to hire them or not. It's the nonverbal. We talk about people who've been abused. And the nonverbal is very clear, no matter what they say. It's the same thing with us. You walk in the room and yes, sparkly eyes, self-confident, looks great, well-groomed, and so forth. Yeah, that makes sense. So it's all the things that you can't measure, but they're real.
Mm-hmm.
Mm-hmm. So if you go on a date with somebody, do you want a second date? I use that metaphor because it's very different. It's not academic.
Mm-hmm. Yeah, makes sense. Yeah.
And therefore you have to be you, which is probably hard. So
It is sometimes.
And be honest and try to enjoy.
I think one thing.
What?
Sorry, go.
No.
I think one thing that resounded with me was that don't be phony, just be genuine.
Mm-hmm. Mm-hmm.
That's one thing you said. That was nice.
Well, yeah, you have to show them what they're going to get.
Yeah.
Okay.
It's like what you. I'm sorry, you were saying something.
No, go ahead.
It's like what you said, it's culturally very different because from where I am at in India, it's not like a back and forth. It's mostly you're very cordial, very formal. You spoke when you're spoken to, at least like it takes a while to build that relationship. But here, I think from the get-go, you have to be like a little informal and casual, and that's a little hard. Like that's what I'm struggling with. It's a little hard for me to be more vocal, I think, from the start. Usually there, it takes a while. You build a relationship and then you get to that point where you can have like a casual conversation. Here, professors and very senior doctors will ask you like, oh, what did you do last night? And that is great. I like that, but it's not something I'm used to right now.
Well, America's culture is very different. We're more open, more casual. You know, a lot of people say that, you know, when a foreigner comes here, if you ask questions, you get really good help from people. They're, you know, we're sort of generous that way, but it's our style. You can't, if you can't ask questions and talk and say how you're feeling, or in a case, you're not going to be part of the team. So I think you'll find that we're more open. And I understand from different cultures, you really have to change your gears. Other people have said the same thing. You sit and listen to what they say and behave. Here you can interrupt sometimes.
From
I can
me
get
personal.
to this.
Sorry.
That was a perfect example too, that I can get used to this. It's more comfortable. I think it can, I think that's how a team should work, maybe, I don't know, instead of just being told.
Well, I think as you know, rightly mentioned, like in India, you know, interviews are more tilted on knowledge, right? So they tilt more on what do you know. They're going to give you case scenarios. They're going to give you like, what are you going to do in this scenario? It's not tilted towards, as you know, as like a know you kind of scenario. So, you know, it's interviews are held differently in various countries, and as mentioned by you, in the States, it's more of, you know, they want to know you. You given after giving multiple steps and, you know, doing multiple things, they already know from their point of view that maybe you're good knowledge wise. So now they want to know you, like as mentioned by Dr. Dharia, the resident who was from Mayo Clinic. So if you follow, you know, general logic, obviously she's good. But then when they pursued the interview in the States, they found out that she was a little arrogant. You know, so I think knowing a person is equally important to being knowledgeable, you know, because you can have the best knowledge and have the best skills, but if you don't know how to convey yourself to the patient, if you don't know how to empathize with the patient, it's of no use, because the patient is not going to come back to you. Patient is not going to like you, and you know, it'll be a problem. So I think, you know, in the States, it's quite well balanced, where they also, you know, they don't have a preconceived notion about you, you know, based on your CV or based on who you were. They also give you the chance to improve and change, you know, and be better and maybe learn from what they teach you. So that's good.
You know, there are many bad doctors who patients keep coming to all the time, but the personality and the relationship is very good. Usually, but what's going to happen is when you apply, they're going to look at your scores, okay? And if the scores are under a certain, like 220, they won't talk to you, okay? They just throw them out, okay? And they have all of your step numbers. They have all the academics, and they have letters of recommendation. So if they decide to interview you, you basically qualify for step one. You qualify to come in and have an interview. Although many now interviews are being done online. Another disadvantage for you is not you, but the new people coming along, is the step one is now pass fail. So they can't really evaluate whether you got a 260 or 240 or 220. And so it becomes more based on recommendations, because rather than numbers. And it's harder for you because you don't have very good people to recommend you. It's a bit, I mean, it's a bit of a problem, but what I found out is that your personal statement has to be poignant. Can't be formal. It has to be probably one of the most important things is why you want to be a doctor. And the real person, you will talk about something that happened in your life that really made you change your mind and want to be a doctor. That's important because that's who you are. It can't be formal. It's a love letter, basically. And then I write very informal letters of recommendation. And people have said that they love it, you know? Again, I try to talk about who you are, what your goals are. And I only do it in 2 or 3 paragraphs because my wife was the director of admissions for a very fancy private school in Washington. And she said, after 3 paragraphs, I don't look anymore. You know, a lot of times you write these very, very long letters and so forth and explain how you got from here to there. You know, it doesn't help. People don't have time to read it. You have to jump out.
So would you say the personal statement should concentrate on why we want to become a doctor and not why we want to go to the United States or to a certain specialty or program?
Well, no, I mean, if your mother had a stroke and you nursed her, that would be a reason why, one of the reasons why you went to medicine. I remember one woman from Toronto, she was here on the remote program, and I think her father had ALS. And that was important for her wanting to be a doctor. I don't have the right rules. It's just like, how do you present yourself in a way that makes sense and it is appealing?
So the letter should help the reader getting to know us, basically.
The letter should help you get into, say that again.
The letter should help the one who's reading it getting to know us, what kind of person we are, what our motivations are. Okay.
Yeah. Yeah. Sometimes I say, this is a wonderful person. You'd be crazy not to, you know, you really should see her. You must interview this person. I mean, things like that. I guess I'm somewhat unconventional, but I find that these letters I write seem to work very well.
Dr. Stein, are you saying that we can be very informal while writing the personal statements? I mean, as Dr. Manisha stated, like where I come from in the medical school, speaking informally to a doctor or senior doctor is considered rude. And I mean,
Well,
and you should speak only when you're asked to be speaking. So,
oh boy, I went to a medical school with no exams. That's how casual my experience was. I went to Yale Medical School, and they have a special, it was amazing. They have a system called the Yale System for Medical Education. No exams at all. Just talk to people. No competition because you're all working together. You can help each other because you're not competing, basically. So we took an exam after 2 years and one after 4 years. Except for that, very free to do your own thing. So my whole, you know, I was very unrestricted, basically, in medical school. And my, you know, again, who are you? That's really the question. And how on a page of paper do you describe yourself?
I mean, how can we put answer to the question like who are you into a few paragraphs? I mean, like describing it in a few paragraphs. I know, at least
I
for me, it's very.
always wanted to be a doctor ever since I watched my mother fall into a stroke. And I struggled with her aphasia for many years. And I wondered what happened, why was she aphasic? What part of the brain was defective? And my curiosity and my love and concern made me decide I want to learn neurology, you know, that kind of stuff. I make this up as I go along, but it's basically if I'm reading an application, well, why does this person want to come here? And it has to be personal. It has to be open. I'm not sure whether I want to become a psychiatrist or neurologist, because the brain is involved in both specialties. And something about you that is important to you, and it's important that somebody reading it would find I mean, the word attractive is not right, but compelling, you know?
I want to do both specialties personally.
What's that?
I would like to do both specialties personally.
Of course,
If I
okay.
could, that's
And
what I
you
would.
write that down. Yeah, absolutely.
It's so interlinked that it's hard.
And maybe I'm, giving you an idea of what the openness of American style, which is difficult because, we're a bunch of wise guys. We talk a lot. We, which is also part of the American ethos, which is you can do anything if you want. You're not as bad as our country is. Opportunity is incredible, and you can't be an opportunist if you're quiet.
Yeah, for me personally, it's one of the biggest reasons why I want to come here. The openness and the opportunities for everybody.
Well, here you see a man who comes to IMG and becomes head of the entire region for OBGYN. So for you, it's really the getting your foot in the door, as you said.
Mhm.
And if you had to go through a small door or a big door, as long as you get your foot in the door, it'll work for you. And that as I think Tarun was very open about sacrifice. I think he was very open about the fact that you were less favored. And that's just a fact of life. That's also why I sometimes recommend getting checked out for accent, because sometimes people have a different way of pronouncing words that are hard to understand. I can give you recommendations, and you can just check out their websites where you can just make a recording and they can comment whether or not you need some help. But really, one point that there are some people who are not as easy to understand. Okay. And if you're involved in a CPR or something, a patient, and you have to call out commands, people have to understand your commands. So I would suggest that you try to get American accents for your words as best you can. This is just, I hate to say that, but these are all the little fine-tuning devices you can do for yourself. If I had two people equally qualified and one spoke clear English and the other really, I had to listen carefully, I would probably take the one with good English. It's not fair, I'm sorry. But that's life.
Is an Australian accent hard to understand? Good question.
Probably okay.
Okay.
But I'll say there's a whole bunch of. May I have it here? Let's see. I can send it to you. Let's see, topics. Exit. Oh boy. There's a
But I do understand where you're coming from, Dr. Stein, because there's some things I say like card and car, and it sometimes gets very confusing for people here.
I grew up in New England, in Boston, and I would park my car at Harvard Yard.
Sounds a bit like me.
It still slips out sometimes. We don't use R's, you know, park, car.
Yeah.
Yeah. But you want to be understood. The other, I've read some articles where patients perceive that doctors with a difficult accent are not as qualified. That's your patient, that's just, you know, that's life. So you do the best you can, but you want to just perfect yourself as best you can.
Was I saying that right? Was that HCA? I know I had to say it multiple times, but was I saying it right? It's HCA.
HCA.
Right. Okay.
Hospital Corporation of America.
I didn't know the full form for that. From what I know, it's a for-profit organization.
Yes.
Okay. How does it differ from something like Kaiser?
Well, HCA makes the money that HCA makes as a profit. They take the profit and to give it to shareholders. Kaiser takes the excess money and puts it back into the program. When I came to Washington, I wanted to be a medical director of a hospital. And there were about 150 openings in the country for psychiatric hospitals. And the hospital I worked at initially was not HCA. It was it belonged to a different company, but friends of mine there worked at HCA. And I was offered a job to come to Washington, D.C. at an HCA hospital. Well, it turned out to be HCA. It was a private hospital. They kept selling to other hospitals, and pretty soon they got a big chain. But I worked, I loved what I was doing, but I was also in a for-profit hospital. And it was difficult because rather than having maximal benefits for patients, I had acceptable ones. We had a thing called EPOB, which is what is it? Expenses for occupied. There was what it costs for an occupied bed. Okay, and they all had these. Everything was at every hospital in the company. They would look at the expenses for each activity. And so I think our EPOB was like, employees per occupied bed. That was the issue. And our ratio was like 2.3, 2.4. We at one point looked at a hospital in Boston, a McLean Hospital, which is a Harvard hospital, and somehow HCA wanted to buy it. Their ratio was 6 people per patient rather than 2. So it was tightly controlled. I thought we gave good care. I love what I was doing, but it was still a for-profit hospital. The money was not turned back to the patient, back to the hospital, but the company. People buy shares in these companies, and the investors have to get their money back. Okay, that's the American capitalistic system. But a not-for-profit, you just put the money back in. And I'm not sure if HCA has training program. Maybe each hospital may have a residency program, but I think you have to be very careful with for-profit companies. You know, medicine should not be a for-profit activity. There's a lot of craziness going on. For example, an equity company with having a lot of money will buy a hospital and then put the hospital, they essentially buy a hospital and take out all the money in the hospital. You know, they sell the land, they take loans, which put the hospital in debt and take the money out of it. It's kind of, I don't understand it, but I know that there's a hospital recently that's going out of bankrupt because it was bought by people who then took all the assets. And now the community is wondering if they can keep the hospital going. It's obviously not for profit is better. But you will go any place you can get there. You know, wherever it is, you go. It's that simple.
From what I heard was HCAs don't actually take a lot of IMGs. So I was just trying to figure out whether, because there were a lot of HCA programs that were listed, and I was just wondering if that is an option.
I'm not aware of that. Each hospital runs their own business, so to speak. That is, put it this way, the finances of the hospital are run by HCA. The medical issues, the medical quality, the medical staff is run by each hospital, because each hospital has to give you privileges. So an educational program will be run by the hospital, not by HCA. In fact, at one point I was called the conscience of HCA because there's very little medical control. I was on a committee, the medical directors advisory committee. We had 52 hospitals, and you know, we tried to deal with quality of care, but each hospital had their own program. So most of HCA's activities were in financing the hospitals, providing for all the, you know, supplies and things like that, maybe advertising, but they're not a medical company. They're a hospital company. And usually each hospital would run the program the way it wanted to.
Right, that's what, it was a hospital, and then it just said HCA at the start. I was paying more attention to the HCA, but now that I understand, I think it was the hospital, and then it must be HCA associated or something.
Right. There's been a lot of questions about quality of care in HCA hospitals because, you know, they have to, some of the money has to go back to the stockholders. And that's unfortunate, but that's the way America works. So be careful about for-profit hospitals. Some may be very, very good, be very good, but you have to look, you know, really. The other issue is that if you're applying, you should know everything about that hospital you're applying to, everything about the program. And I think it would be helpful if you know enough about the hospital to have ideas about how to make it better. And this is the problem become when you're quiet and wait to be called upon. It's hard to be a person that says, you know what, I think we could add I have an idea adding to your program, you know? We should have an outreach program for kids with Tourette syndrome. That is, you're both quiet, receptive, respectable. On the other hand, I want somebody who's going to help me build my program. And that's, you know, I'm not hiring you to be just to be nice. I want you to be to help me in my ideas. And so when I used to hire people, I'd say, I want you to look over the programs. And for the first 2 or 3 months, you'll know what's different and strange. After that, you'll just be part of the program. I want you to look carefully and let me know what you see and how we can make things better. And that's hard to ask a new person. But on the other hand, you can't be passive. You're offering yourself as a person, obviously, who you are, but you're also offering the possibility of how you might work in a program.
But what if it
Mhm.
comes out as being arrogant? Like instead of talking about a program that why they should take, you're talking about how you can change, like what changes you could make to their program. So it could
Obviously.
sound arrogant as well.
My son worked in hydrogeology at National Laboratory. He wanted to switch to an organization and a company called doing solar energy. He wasn't really trained in solar energy. He only had a PhD in hydrogeology. So during the interview, he pointed out some of the mistakes in their statistics, pointed out how they had done some miscalculations. So he came there to quietly educate them. That's the kind of person you want. Not someone who sits quietly and says yes and smiles. It's a big transition. I understand that. It's a real big transition. So what should you be aware of? What's going on in American medicine? COVID. What about the long haulers? Do we have a program for long haulers? No, I'd be interested. I've been thinking about this, Doctor. I'm really upset. I think that the future for many COVID patients will be terrible. I think they'll have neurological problems for quite a long time. They will not be the same as before. And I'd like to put a program together with social workers and psychiatrists and internists and pulmonologists to see if we can find a way to help these people. Whoa, that's interesting. Rather than say, I'll be quiet, I'll be a good girl, and I'll do what you tell me. So you study the program, you study everything that the program director has done, all the papers he's written. So you get a sense of who he is, what he's interested in. And you just find a way, it's basically selling yourself, How do you make yourself more interesting? I don't do the dating websites, but I think people somehow have to advertise themselves on dating with, this is somebody you want to have a date with. It's the same kind of thing. You're switching from becoming a student to becoming a provider. You'll be providing care to these patients. So you have to subtly switch your sense of self. Tarun started out like you, and look how he switched to be in charge of everything. And that's very subtle, but it's, think, it's like, if you're hiring somebody, you have 4 or 5 people to choose, who would you choose? So this is off the cuff advice.
I did want to ask, when you're interviewing, as you said, you have to sell yourself, but is it, would it reflect badly if you were aware of your own shortcomings? Because if I were to say that I come from a background where we generally are more formal and cordial, but I am open to being more vocal and sharing my ideas, etc. Is that something that they would look down upon because I'm saying that I come from that background, so they might think that, oh, she's going to have a hard time transitioning to our system? Or could it seem like a good thing that at least she knows what she has to do?
No, you should be who you want to be. It doesn't help giving excuses or an explanation. I don't think it'd be that helpful because that's your problem, not theirs.
Right.
And I don't think they have to even know about it. It's like, it's one of the burdens you have, whether you like it or not, to become more of a candidate they want to have. Yeah, I know you're shy. I know you came from a different culture. Tough.
Right.
It's very simple, tough. You have to play the game and realize what American culture is like. It's open. It's not as formal. People say more things than you would say. The other problem we're having right now with the social media is that all the things that people would never say are now being said. Usually, we all have a rotten part of us. We usually politely keep that quiet. But now it's crazy. People are just, spewing out all this filth and anger and so forth. I thought that's a bit, maybe an afterthought, but you have to do your homework. You won't say, well, I have a little problem with my English. Some people don't understand me that well, but I'm working at it. No, fix it. Okay, just fix it.
Thank you for that, because I think, that is something I will work on, but I won't say that I'm working on it. I'll fix it and then I'll get there.
Yeah, absolutely. You have to fix it. Because they don't care about your burden. I really don't. They don't, they don't know whether you stay up all night or work. I mean, they don't care. They shouldn't care. That's your problem. No excuses at all.
I think you probably have to find a balance between, especially when they ask questions about your CV, for example, things that can't be fixed anymore, for example. So to find a balance between an explanation and an excuse, so that you can explain it, but you don't make up an excuse for it.
No, and if you
It
had
can be hard, I guess, but
being open, it might be, you might say that I had a problem first with step one, and I took it seriously and I studied hard, and now I'm doing great on step two. I mean, again, you can't hide anything. You shouldn't apologize for yourself. It's okay. A real person sometimes has troubles and overcame the troubles because they want to know who you are. The excuses are for yourself, not for them. Because they don't want a resident who's, complaining about her difficulties. That's not their problem. They want you to be effective on the job and competent when you start. So you have, you'll struggle with your own issues and try to make them better. I mean, you come across very real.
would there be an option? I mean, it's still some time until then, but when we apply and when you write our personal statements to get back to you, and maybe you can help us with that.
I'll be happy to look at them. Sure. Yeah, absolutely.
Thank you.
Yeah. I used to say it's a personal statements, but I'm not sure as examples. I'm not sure if I have many here. Let's see here. Let's see. Let's see here. Okay, here's a personal statement. It's all the names are taken away from it. Let's see if I can how do I send this to you? Oh. I think can you get your chat box?
Mhm.
Okay.
So it's usually 1 page long.
Well, they're not going to read it. They get sometimes 1,000 applications.
Mhm.
Dr. Stein, it actually doesn't show in the chat for me. I can just see like one notification, but I'm not being able to access it.
Okay, let me try to send it email wise. Let's see, compose. I have to find your addresses. Where are they? There we go.
Would you excuse me for 1 second? I'll be right back.
So what would be the limit, you would say in terms of paragraphs that, you would read, as you mentioned?
I guess, actually, Jenny, when you were doing admissions, how many pages would you look at? No, what, a whole page or 2 pages? What was too much? Really, what was too much?
What are you asking for? What is this for?
A personal statement to, when people, huh?
Page and a half.
Page and a half, okay. Page and a half, that's my expert. Let's see here, compose to paste. Okay, there you are, subject, personal statement.
Keeping it within a page would be better.
I think so. I mean, the tendency, it's much harder to write a short letter than a long letter. A long letter, you just sort of, just keep going on and on. But also, like in presentations, it's hard to give a short presentation that people will accept and hear, rather than a long presentation, which gets boring after a while. I really mean that. It's like, what am I doing? Gosh, I'm for, what are we looking for? Personal statement, let's see here. Because you're writing this mostly for what someone's going to read, besides your mother, who will read everything. You're writing it, in terms of how do I say that? You're writing it so they want to talk to you. That's the whole purpose. They don't want, you have a wonderful long story. We all do. But that's for your mother and your friends.
Also, as mentioned, in one of those last lines in the file sent by you, she had mentioned that that's one of the reasons she should be selected for the interview. So what my query was, could you say that, like, would you come off as arrogant that that's why you should select me for an interview, or is it understood that you're talking in a nice way?
Well, you could put something like that. I think your program is fantastic. You offer all the things that I'm interested in, and I believe I can bring to your, I feel I have a lot to contribute, something like that. It's boring to read formal letters all the time, one after the other. And basically, all letters of recommendation are good. They're all good. And so they have to be better than good. Something about you have to jump out to impress people. I mean, this is ordinary. I mean, I'm not making it up. It's like, if you're sitting down, you have a whole pile of applications, you just go through them one after the other. Oh, this is interesting. That's the way it works. Your microphone is off.
Yeah. So, like, if you're going through an application, what would you say are the first 2 or 3 things you see regarding the applicant, like maybe scores or interest? What is seen initially?
What
as
did
an
I have?
interviewer?
Let's see, what do I have here? Okay, the one I used here, it says, I was in high school when I was hospitalized for the first time. I had a liver abscess. I was overwhelmed and I was inspired by the doctor who cured me that I decided to become one myself. Okay, that's a very good introduction. It's about, hang on here. Then she talks about medical school where her family members are sick, okay? And she, talks about how she was involved with her sick family people. And she talked, I mean, all this stuff is really interesting, strokes, cancer. I mean, to read that, it's why someone wants to be a neurologist. I found this sort of I think this is a very good letter.
No,
It's
like,
informal and real, right?
what I meant was during the match process, like what are the, not just a letter, like in general, what are seen first? Is it scores or is it personal statements? What is initially seen by our interviewer?
Scores are first, there's no question. The residency programs I've talked to and heard about, I think it's under 220, they won't talk to you. But once, if you qualify academically, then the next question is, who are you? Do we want you? Do you fit in? So you spend all of your time getting your CV done, working hard on, learning knowledge and so forth, but they don't care. They assume that you know these things. And they're not there to question your medical judgment. That's done with. The whole thing is, do I want you? Do I want to work with you? Will you fit into our team? That's why the interview changes, because it's really, I want to get a feel of this person. Do I want to go on a second date, which lasts 3 years? And those are things that are, intangible. You can't really measure them. But it really is a person-to-person kind of thing where the interviewer feels good about you and can predict from talking to you how you might behave and fit into the program. That's all right brain, not in words. It's a feeling, it's a sense you have. This is a person I like. This is a fun person. I'm comfortable with this person. She has some good ideas. And she's done her homework. She knows about us. She knows everything she can about us. At least that's the way I see the world. And I know very quickly when I meet somebody within the first 2 or 3 minutes, how comfortable I am with them. And so if you're faking it or trying to be, super proper, that might not work. I mean, you have to be yourself. And of course, I'm not saying you have to be, boisterous or gregarious, but you just have to be genuine, which sometimes is hard to do when you're in medical school and just being compliant. If that helps at all. It's, I would not want to be in your shoes. It's hard work.
Yeah, but I think it does help. For me personally, it helps a lot.
Are you the person that I would feel comfortable having talked to my patients? We'll keep talking about this, and it's a difficult transition. I understand that. It is. And the more comfortable you are, being yourself, and you may want to, I don't know, have interviews. maybe practice. I'm not sure. I don't know about practice interviews. It's not a, it depends on yourself. If you, the more you feel comfortable being who you are, and it's okay, and you work very hard, and you have a passion, you love medicine, you want to help people, and maybe a reason why, well, why did you get inspired? I always wanted to know what doctors knew. It was a crazy thing. I did not go to medical school to be a doctor. I went to medical school to learn what doctors know. That was my crazy thing in my head. I want to know the mysteries of medicine. I want to know how the body works, but it was a curiosity. That was my thing. Okay. People who went for medicine for all these different reasons. My father was a doctor. My uncle was a doctor. Being a doctor is what we do in our family. Well, okay. My best friend died of a brain tumor. I want to fix that. Whatever. Last rotation, one of the women in the practice has epilepsy. She wants to become a neurologist because she has epilepsy. Isn't that a powerful statement?
Yeah.
Mm-hmm. And you can say, because I have epilepsy, I know things that other people don't know about epilepsy. I know what it's like to be a patient. I know what it's like to have my brain play tricks on me. I think I'd be very valuable because I know things that are not in the textbooks and I can help people.
Thank you, sir.
She's taking a liability and turning it into a positive. I would be, if I'm interviewed, I'd be very, very struck by that. How did you overcome your epilepsy to manage to get to medical school? I'd probably ask questions. Well, when was your last seizure? How do you deal with it? How controlled are you? These are tough questions. They should be asked. And how you answer that would, on the one hand, you'd be very valuable. On the other hand, you might be a liability. But I think dealing with that openly makes you a real person.
So like when you mention things like that, obviously, it adds a personal touch. But as you mentioned that certain institutes might consider it, a great reason to join, and some might consider it as a liability. So how do you know where you would fall when these instances are mentioned by the applicants? Like,
You don't know.
how do you know you should mention or you should not? Since it could be a reason some institutes might not take you. As you mentioned, they could consider you a liability. Some might consider it as an actor.
Welcome to life. I don't know the answer to that. I don't know the answer to that, but this woman wanted to become a doctor because she's epileptic. So that's it's a very big statement. In this New England Journal articles called Perspectives, I remember, you got to get that. It's a great journal. And it's cheap. But I remember one woman had Crohn's disease, a resident, and she was treating a patient with Crohn's disease, and she was wondering whether she should share her problem with the patient or not. I mean, it was just, thinking out loud, should I? She did not, but some people do share. But again, there's not an easy answer to that. Do you share your epilepsy with the interviewer, or do you not share? If it's a positive story of conquering this illness, I think it probably would be very valuable. All of us have an outlook in life. All of us were brought up in a culture. All of us were brought up in a family, which had certain rules and customs, and you bring that with you. That's who we are. And then you can decide if there's some parts of you that you want to modify or change. But you carry the burden of your past, the burden of your genetics, the burden of your experiences. And that's who you are also. So, somehow in that process, you have to distill, with all this stuff going on, why do I want to be a doctor? You notice that Tarun constantly says compassion and caring. All of his life, that's what he talks about. So when talked about, and that makes him very attractive. It's not the money, take care of everybody. Dr. Bernard in that tape yesterday, he says, doesn't matter whether you're on the street or an ambassador. And he does in his office have one day an ambassador comes in and the next patient is a street person. That's the kind of doctor I want people to be. We had one person a few years ago in this program who wanted to become a doctor to do hair transplants. That's all they wanted to do. Crazy.
Just along that line, I wanted to share a story with you, Dr. Stein, and everyone. So I was, like I said before, I was working in a family medicine clinic. And we saw everybody. There was no distinction or choosing people based on their insurance. It was a walk-in clinic. And then I was leaving there to come to DC for this rotation. And on the way, we met with a friend of a friend. And he was saying to me that, oh, I heard that the place where you are, it has a lot of people who are lower socioeconomic and all of that kind of thing. And, how did you treat them? And he said a very very disheartening thing. He says, I mean, didn't they smell or something like that? And my immediate response was I don't notice these things in people at all. They are my patients, and this doesn't even come into play when you're seeing or when you're doing anything. It's the person that you're looking at. And it brought home to me that it's like the topic we've been seeing the last few days, that as a doctor you have that privilege to really see a person as a person.
Absolutely, yeah. Yeah. That would be a wonderful story during an interview. If I heard that story, I get a sense of who you are, what your values are, how you care about patients. That would be wonderful.
Yeah, because
I mean, to tell that story.
I mean, that it really, everything you've been saying to me and what I've been hearing from Dr. Bernard, it's as doctors, we don't even consider what a person looks like or smells like or this or that. It's that's not even part of consideration of who they are.
It's rare, by the way. It's not common these days. Oh. But yeah, Bernard's a wonderful doctor, and he takes care of everybody. Mm. Mm-hmm. He took part in President Trump's brother's care. He's going to Saudi Arabia to take care of the princess. He also takes care of the street person. That's very unusual, by the way. And you have to, it's complicated to fit it into the realities of your life, what your income has to be. I think Dr. Med I'm not sure if he runs a practice in a very unusual way, but I'm not sure that, other people can do the same thing.
And if I can add to that, Dr. Stein, Dr. Bernard has 3 offices, and within the 3 offices, you'll see the dynamic of change in the type of patients you will see. For example, in the Woodbridge office, you'll see more the patients that have Medicaid, low source of income. In Alexandria, you'll see the middle class. And then in DC, you'll see the more educated patient come in. So you will see that 3 different type of class of patients
Mhm.
within the rotation.
And we treat them all the same way.
Exactly, yes.
Now, sometimes we can't. Sometimes we can't get certain tests because the insurance company won't pay for it. I remember a patient at Grand Rounds at George Washington University where the patient had failed all the anti-epileptic drugs. We wanted to do a vagal stimulator. It wouldn't pay for it. So we had to struggle with going around. We couldn't use the vagal stimulator. Dr. Bernard sometimes cannot get permission to do an in-house sleep study. Sometimes we can't get permission to give expensive medications. We try. So people don't always get exactly the same care. They get the best care we can give given the situation of their life. We try very hard.
And I saw that often in that family medicine clinic because there were so many patients on Medicare, Medicaid, and some were even self-paid. So then the way the doctor would try to work around it.
Mhm.
And maybe the care wasn't optimal, maybe it's not the things we learned in a textbook, but it worked.
Mhm.
And we tried to bring the best outcome we could for our patients, working with what we had. So, and I thought you have to be really creative. At times, he was trying to take care of diabetic patients, but with the generosity or whatever samples drug representatives had given.
Right. Yeah.
He would save those samples for those patients who couldn't afford it.
And that's
or
what
be able to
Dr.
get it.
Burnett does a lot, is that he helps those that don't have the income or the insurance that are willing to pay for these medications, is that he does help with saving samples for those who can't afford it. Another role that you guys will be playing for these type of patients is the more details you guys put in the encounter, the better chances they have of having Medicaid approve a certain medication. So there are, certain things that they're looking for, not so much based on do they really need it. They're looking at requirements that they've set up to see if they qualify. They're not looking at what the doctor thinks that will help this patient get cured or help their symptoms. They're looking at what the requirements they need to have to either approve it or deny it. They don't care too much about, is this going to help this patient? They care more about cutting costs. But your job and Dr. Burnett's job is to try to add as much information possible to make sure that that insurance will approve that medication or that testing.
So how does
It's
it work? Is
inspiring.
it, oh, sorry.
No, go.
How does it work? Is it in that kind of case that the doctor has to write a request to the insurance company, and
Yes,
then they have to look up the case and decide based on the
exactly.
information?
So let's say we're talking about a medication. There are certain guidelines that a patient has to meet to get approved for a certain medication. So let's say the doctor wants to prescribe a new drug. Well, the insurance is going to say, well, we're not going to approve this because they haven't tried this and this and this. So it's like kind of a process. So when you see this patient, you got to ask, have you tried this? Have you tried this? Have you tried this? What is the outcome? How long have you tried it? Because those are questions that they will ask the doctor once he's trying to get this medication approved. So there is a process, they have to go through several things before they will approve something. In regards to like testing, let's say the doctor wants a patient to have an MRI. Well, there are certain things that will need, certain requirements that the insurance will need to approve this MRI. Well, let me give you a better example, a sleep study. So for a sleep study, a patient needs to snore. Patient needs to have at least some type of medical issue, either lung issues or heart issues. Patient might have to wake up gasping for air. Patient might have to, wake up several times in the day. So if you're writing your notes and the patient says, oh, I have these issues, blah, 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 and you only put patient has headaches or patient has sleep problems, and we try to get a approval for a in-home sleep study or a lab sleep study, they will flat deny it. Why? Because we didn't put the snore, we didn't put the patient is gasping for air. We didn't put the patient has issues with heart problems or heart disease or pulmonary problems. So those are the things that, you know, needs to be added in the encounter when the patient is there. Try to get as much information as you can, because at the long run, it will help the patient get approved for certain studies that they will need to, you know, feel better and be able to have a good treatment plan for the patient.
In these scenarios, would it be like as an attending or a resident, would it be unethical to personally pay in case through our pocket if the insurance companies don't, you know, allow a test for a patient? Is it considered unethical? If
For
a,
the-
if a if an attending or a physician pays for the patient himself if it's actually needed, because certain health insurance companies, you know, they don't they deny multiple requests even though the patient might need the test, or certain drugs are not covered under certain health insurance you know, companies. So is it unethical to maybe try to help the patient from our side personally, or we should follow the hospital protocol?
What is unethical potentially?
No, and that's my query. Like, would it be fine if we could pay on our own, you know, to help the patient out in case the insurance companies reject?
Well, you do everything you
op-
can to help the patient, basically.
So it's fine if we could also pay on our to help the patient.
I'm not understanding you that clearly.
Means like pay through our own pocket. So the physician would pay through his own pocket for the test.
That's very
the
generous.
patient in
I'm
case.
not sure. It depends on, I'm not sure. It's a personal issue. If you want to pay for the patient, that's fine. Or it's up to you. If you have a lot of money, you could do that. But, you know, that makes a very special relationship with the patient, which may not be that helpful. Realistically.
I would say almost it's unsustainable, because it's not just one patient, it will be many patients
Yep.
who could be in that.
Yep.
And I guess it's more working around and figuring out how to best use the system, if that's the way of putting it. I don't know. But
We're in the era of,
in India.
go ahead.
Yeah, I mean, in India, it's a very common practice in private settings. Some of the doctors pay out of their pockets for many patients' tests and their medicines. So, I mean, I think, yeah. I mean, it would be very costly in the States, I guess, but yeah, I think Dr. Nanavati was referring, I mean, his question came from that point of view.
I'm not sure you can afford to pay for that for your patient. I don't know the answer to that. But, you know, we're in the era of an evidence-based medicine. It used to be the doctor that wrote a prescription for a test that was just done. But you're accountable for really making sense of your request. As Melissa said, you know, I mean, if there are good reasons and you can write them down, that's pretty useful. But you just can't casually say, I want this, this, and this, because these are expensive tests. MRI goes from $5,000 to $10,000, for example. And it's really, you have to justify it. And there's an appeal process. He first gets denied by a secretary who has a list of rules in front of her. And then it's not a medical opinion. The first denial is administrative. Is that correct, Melissa? Yeah. I can't hear you. Melissa, you're not coming through. Oh.
So basically yes, in part that's true. It goes through, you know, the secretary. You call in, you let them know, okay, I want to get this study approved for the patient. They'll ask for diagnosis. If the diagnosis is not what they have on file, they'll deny it. And then it'll go through a review process. At the review process, that's where the actual physician takes a look at the case. And then even though there would be good reasons to do it, if you don't give those good reasons, it would be denied because it's not enough information.
I think
So
as
yes,
mentioned,
versus the basically secretary going through the rules and seeing check, 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 or denying it right on the spot. If it is denied right on the spot, it'll go to a review, which is the physicians that the insurance hires to review. And then from there, if it's denied, it can go through a appeal process. And that's when the doctor himself have to talk to the doctor at the insurance company, and they will discuss it between them. And then you either get an approval or a denial.
And that takes a lot of time. Sometimes you have to hold on the telephone for 20 minutes. And in a busy practice, you may not have time to do that.
I think from our side, we could make the history encounters more precise. As mentioned, we could tick box every criteria that should be met for a specific test if needed to a patient to avoid this lengthy process, but at the same time, give the patient all what is owed to him. So yes, we could make our history encounters more precise, as mentioned earlier.
Does the doctor at the insurance company, can he decide entirely on his own? Is it his own opinion, or does he have rules so he can't really? It's not really his decision at all. But does it rely entirely upon him?
Well, yeah, if it's a medical request and a medical doctor reviews the chart, I expect that they, will offer a decent medical opinion separate from the insurance company's issues. And I think even a higher level of appeal. But it's a long process. And, there are a lot of things we don't have time to do. For example, if the patient has an adverse reaction to a medication, there's a whole report you can send to the FDA, but it takes time to do that. It takes maybe a half hour to fill out the form and so forth. I call them. So a lot of times we just don't have time to do all the things. Like it'll be a point where you say, I can't do it. I can't have it spend as much time as I want to get this approval. Or you do it when you go home at night and take away from your family time. So these are all the struggles you have in medicine. And people like Melissa really helps make it work, right?
Yes, it's not just the doctor. The doctor has to hire overhead to get these things done because he doesn't have time to do it. So he relies on his staff to get it done, and when there's a point where the staff can't get it done, then it relies on the doctor, and that's time away from his time to see patients. And that's where the money is coming from, is the patient not doing all this paperwork. And I think that the insurance company has made it into where a doctor has to go jump through hoops to try to get these things approved for their patient. And they know a lot of doctors won't do that. So that also, saves cost on them to where they don't have to get all these medications or diagnostic studies approved. And at the end, even though the patient is paying for their insurance, they get the short straw because they don't get, they don't get the benefit of what they're paying for, basically.
This is why working for an HMO like Kaiser is so much easier. They take care of all that work. But Melissa's right. I mean, the office spends so much time dealing with insurance companies.
Just out of curiosity, is there anything that regulates these insurance companies? Like in case they are not, like you said, they add the paperwork so that doctors have to jump through hoops and make it more difficult for the doctors essentially. So is there something that is keeping a check on that? Some organization?
I don't know.
The thing with the insurance company is that for you to work with an insurance company, there is a contract that you will sign. So you're basically letting them know. They will tell you, well, for this and this and this, you got to meet this and this and this. And if you sign that contract, well, you have to follow by their rules.
So once you enter the contract, there's no way really to, there's no way out then. Like you have to sign.
Well, yeah, you can cancel it. You know, you don't have to stay with them, but you know, when you do decide to work with insurance companies, you would have to follow their guidelines.
Now, there are many doctors these days who will not take insurance patients. It's all cash only. They don't want to deal with it.
I
But
thought
if-
insurance
ahead,
was
you might-
quite
What's that? Say it again.
I thought insurance was, like most people would be having insurance. So on,
Most people have some kind of insurance. The insurance for poor people who's Medicaid is not that reasonably, they don't pay that well. And you as a doctor can choose what kind of insurance company you want to work with. So just as I say that there are doctors who will not take Medicaid patients, some doctors won't take Medicare patients, and some doctors who work in a fairly wealthy area, I would say we will not take insurance at all. Dr. Manad is very unusual. He takes everything.
because ideally it would be unfair to patients who have Medicare or Medicaid for not getting their share of treatment just because the physician does not approve of their rates. I think patients should be seen irrespective of what insurance they hold.
The ethics of the American Medical Association says you can choose who you want to treat. That's in a private practice. If you're working for an organization, you have to treat whoever they give you. But you're not obliged to treat everybody who comes to your office. You can choose.
Actually, I find it very interesting. You know, we were talking about the different healthcare systems in different countries the other day. And basically in Germany, it's kind of entirely on the other side of the spectrum in comparison to the United States. We have a state insurance, basically. So everybody in Germany is insured. And somehow it still comes down to the same problems that basically the bureaucracy is interfering with patient care. So I think it's not an easy answer to how to improve the system, because like I said, it's basically the same problems in Germany, even though everybody has healthcare and is insured, and it's still the insurance companies that interfere with the patient care, basically.
And many people have private insurance also, is that correct?
Yeah.
Yeah, right.
But it's becoming less and less. And the politicians are even talking about canceling private insurance companies, private care. So the state insurance companies would hold even more power, and that probably would make it even more difficult.
Which is completely the opposite in Australia. So what's happening there is people are relying more and more on the Medicare and government healthcare rather than getting private health insurance. So they're putting more burden onto the public health system. And there the incentive is that if you get public, you get taxed less. So they want people in Australia to get private health insurance. The other way around. They want to keep that because it takes the burden off the public health. So yeah. There's no talk of getting rid of public health in Australia. They need more people to actually pay for it and do it, because it keeps public health for those who need it, who can't afford private health.
That's very interesting. I think in Germany they want to cancel the private insurance companies, because that kind of gives people a way out, you know. So, and doctors too. So doctors can say we only treat patients that are privately insured. And patients can say, you know, we don't want to deal with the public insurance company issues, so we get private insurance. So that kind of puts pressure on the state insurance companies, because they have to become more appealing to get people to be insured with them. And if they just cancel the private insurance, everybody has to be state insured. So they basically can do whatever they want, because, you know, nobody can say anything against it, because it's basically the law that you have to be insured.
We try to do that. We tried this country to make sure everyone was insured. President Roosevelt tried to do that. President Truman, President Kennedy, President Johnson. We still do not have our country agreeing that healthcare is a right. It's still considered a privilege in this country. And we, you know, a lot of people talk about Medicare for all. The last election, Bernie Sanders, who was running for president, really, you know, that was his platform. But our legislators don't want to do that. It's complicated. And doctors choose. I mean, there are doctors who, you know, plastic surgeons, for example, you know, doing cosmetic surgery. The insurance company won't pay for that. You pay for yourself. And the problem is that you still may want to see a certain doctor. And you can, you know, you want to, and you may have to pay to see that doctor. And so, you know, if you have money, money works. It's always that way. And unfortunately, often the least competent doctors take the cheap insurance like Medicaid. We find sometimes the patients are, you know, not being treated exactly the way we would like them to be treated. Is that correct, Melissa?
Repeat that again.
Some of the Medicaid doctors are not as good as the regular doctors. Is that correct?
That is correct.
Yeah. Yeah. There are also insurance company, when the Obamacare went into effect, it said there was like 10 different things I had to cover. You know, pregnancy, drug abuse, whatever that was. But there was a certain list of diagnoses and problems that had to be covered. But certain private insurance companies will not do that. They'll only cover certain things. And patients always know that. And, you know, it's hard for people to know exactly what coverage they have for what particular illnesses. For a long time, pre-existing illnesses would not be covered by insurance companies. It's a big issue. So if you had diabetes and you wanted to be in a program, well, we will not take care of your diabetes. That's a pre-existing illness.
And we had, when the Obamacare came in, we had a lot of problems because patients would go in and try to find the cheapest insurance they can get. But then when they come in the office, they don't realize the coverage of the insurance. So basically, they're paying about $50 a month, but they're out of pocket before the insurance will start to pay anything with their services. It's, you know, $1,800 or $2,000 or $3,000. So they're here coming into the office thinking that they're covered, yet they still have to put out of their pocket a large amount of sum before the insurance company will start paying for their services. So that was, you know, a big thing early in when the Obamacare started. It did help a ton of people because, like Dr. Stein said, you know, the insurance company couldn't deny you for past previous, you know, diseases. So if someone had seizures since little, an insurance company would not say, oh no, we're not going to treat that because you've had it prior to getting your insurance. So that's something that helped millions of people. But then again, for those who probably didn't have that big of an income, and they were here thinking that they were going to get full, coverage, they would go in, pick an insurance company, and then little did they know that they weren't covered for much, that they still have to, put from their pocket before the insurance will actually start working. So it was, it was beneficial to certain people, and it wasn't too beneficial to others.
When you pick these insurance, where $50 a month, isn't it explained as in what comes under the coverage? As you mentioned, they were not aware.
The thing is that a lot of people don't read and they just pick, and they're not aware of these big words, and they don't do a lot of research. So a lot of people didn't know. They said, okay, I can afford $50, $100 a month, but they didn't read the fine print that said you have to pay out of pocket $3,000 before we can pay, start paying for your services. And even now, people come in and they have no idea what their coverage is. So, as the front desk, that puts more pressure on us because we have to go and investigate what is going to be approved, what is not going to be approved, if your first initial visit is covered fully, if it's just partially. And then when the patient receives the big bill, they're upset with us, but it's their insurance company that only covered for a certain amount. So they are responsible for the rest. But we do see a lot of people coming in and they don't know their coverage, even though they're paying monthly.
So basically, is it your job then that you have to call the insurance and ask about that kind of stuff? So that falls entirely upon you?
It falls on the front desk because we need to know if this patient is covered or not, because at the end, if we do provide the services and the insurance says, no, they don't have this coverage, then the doctor loses, so you have to rely on your front desk to make sure that everybody that comes into the office has an active insurance and they're covered for the certain services that you're providing.
Often when you're called to make an appointment with a doctor, the first thing we'll ask you is, what is your insurance?
Yeah.
Okay. And they may say, we don't take that insurance. You can't go. It's a real problem.
Can't the patients come to the doctor's office and ask for a suggestion on based on their conditions to suggest an insurance company or insurance? What plan should they take upon?
I'm having trouble understanding your accent. Okay.
No, I was just wondering if the patients could come into the doctor's office and ask about what insurance plan should they opt based on their condition. So some doctors they'll be very much informed about the insurance policies.
I don't think doctors really could answer that question. That's we don't know what insurance companies cover. We don't have time to do that. It's really your problem, basically. We're too busy to do that. We'll check your insurance, but we don't advise people what insurance to buy. I don't think we have that time really or expertise.
So the doctors really don't know because they don't get into that, but your front desk will. So your front desk will, because they're the ones that, are talking directly to the insurance company when you're getting approval or when you're checking the eligibility. So for example, this past year, they started doing with Medicaid and Medicare, they combined it together. So it's a dual plan. And of course, basically there are the private insurances that are going I guess you can say they're the middle guy in the whole thing. So now they have Medicaid with United Healthcare, which is a private insurance, or with Blue Cross Blue Shield, which is a private insurance. So they're selling this, but at the end, the patient is not getting the best benefit, because with Medicare, the patient pays, a patient is responsible for 20%, and then the insurance covers the 80%. So usually with patient with a Medicare, we'll have a secondary to cover that 20%. So they're 100% covered. So now they have this new plan that is a dual plan, which you have Medicare plus, let's say, United Healthcare. What they're not telling the patient is that they have to pay for a copay every time they come in to see the doctor. And there is a portion that is not covered. So they're, paying less, but not covered fully as they were before. So when patients call and they want to stay with the provider, they tell us, do you think we should change or should we stay? And a lot of them didn't tell us. And then, we weren't in network with this new dual plan, so we couldn't even see the patient. So they have to wait until enrollment to be able to change the insurance that they have. So the front desk does help to let the patients know, what insurance really cover what they need and what insurance doesn't. Of course, it's not the responsibility for the front desk to do it, but we care for our patients because we see them every month, sometimes for years and years. So we let them know what's going on, in the insurance industry. Sometimes information that they're not aware of.
In these instances, as you mentioned,
Right.
quite a few patients find out later on that they have to copay. So how do you deal with scenarios when they refuse to copay? How do you deal with that?
So we let them know this is what your insurance requires. This is what you gotta pay to see the doctor. So they either pay it or they reschedule or find another doctor, really,
Did-
Go ahead.
Does this payment discussion happen before they start with the doctor, or is this after the appointment?
It depends on the insurance. Most insurance companies send the patient a little card, and it will tell them if they have a copay or not. It will say $30, $40, $50. And then they are aware that this is what they have to pay to see a doctor every day. Now, in regards to deductible, that's something completely different. Deductible is that they have to meet from their, let's say this patient has a $500 deductible. Their plan starts in January. So they come in and see the doctor. The charges are, let's say, $400. So they will receive a bill because they haven't met their $500 deductible yet. Once they pay those $500 deductible for any services they receive either with us or anybody else, then their insurance company starts paying everything else. So a lot of people don't know that. Like I said, they don't read well when they're signing into, their contract with their insurance company. So we tell them, and of course they will be upset with us, but there's nothing we can really do, So most patients know, but not a lot of patients know. So in the beginning, if you're accepting, and let's say you're going to have your own practice and you're going to accept insurance companies, your first couple of months are going to be harsh. January, February, March, because that's when the new year ends or starts. The new year starts for insurance companies. So the patient has to meet a certain deductible before the insurance will start paying full. So you're going to start, needing to bill the patient and wait for the patient to pay you. Now, some doctors, they call your insurance to see if you have a deductible or not right away, and they won't see you until you pay that, that amount for your visit, because they know that the insurance is not going to pay for it. So it really depends on how the doctor wants to structure their office. You either bill the patient or have the patient pay right on the visit.
There are also insurance policies with very, very high deductibles. And they're really almost only for emergencies, like a $5,000 deductible. They have policies like that.
Mhm.
And only when, a very expensive bill comes up will the insurance company pay. But otherwise, you pay yourself. There's all kinds of policies you can choose. You get a sense from Melissa how difficult it is to run a practice. All of this stuff has to get paid for with extra staff.
Exactly.
Yeah.
So if you don't have the right staff, you're going to lose a lot of money. And that comes to play for you as well as the provider. You got to make sure that you are giving the most detailed encounter that you can give to make sure that, whatever you're trying to do is covered based on the criteria that they're looking for.
I think most patients are insured by with their work, right? With their job company, basically. So can the patient choose what kind of insurance he wants, or does the company that he works at decides which insurance he will get?
The company they work at decides.
Mhm.
And interestingly, your insurance may pay for abortion, but a company may want a policy that says no abortions, very religious,
Mhm.
and so you can't get, or birth control. They may say, we will not pay for birth control. And the policy may come out that way. And people fight that, but this is, everybody has a different policy. So yeah, you're stuck with what your company buys for you.
Mhm.
So working in a clinic where everything's taken care of is much easier. But you don't have the freedom that Dr. Burnett has to create a practice that makes sense for him. If you want to go to private practice, do your residency or your training in a rural area where they need doctors. And then you have much more control of what's going on because you're really important, you're needed, and you're not stuck in a very complex bureaucracy. It's very, very difficult. I mean, Melissa's amazing. She really helps Dr. Med make it work, but a lot of work. It gets harder each day.
There's new regulations and new rules every day. And, the amount that they are adjusting on each patient every month is really hard for a private practice to stay open. Most private practices have joined a group because they just can't afford to stay open because the insurance company are, cutting their costs or cutting their gains, basically. So back in the day, the insurance company will pay whatever the doctor requests or thought that, their services. So let's say office visit was $400. The insurance company will pay those $400. But now it's not that. It's not like that. They've adjusted it. So the doctor can request for $100, but the insurance says, no, we're not going to pay you that. The allowable fee is $200. So that's what you get, $200. And nowadays it's not even 50%. It's more like sometimes 35 to 40% that the doctor gets, and then everything else gets adjusted. And it's not just private practice, it's hospitals and everywhere. For example, I had a gallbladder a couple of years ago. I had surgery. The hospital charged the insurance company like $67,000. Well, the insurance company came back and said, no, we're only going to pay you $15,000 out of those $67,000 that they, were requesting. So everybody sees it, hospitals, private practice, clinics. If you work with insurance companies, they will adjust what you bill.
I told them my hospital last few months was $400,000.
Wow.
Obviously, Kaiser will not pay that amount of money. You know, it's the money that gets paid is much less than the money the bill they give you. It's negotiated.
Yep.
So this benefits the patient because the insurance company will negotiate for the patient with the provider. Is that how that works? The insurance company decides how much money they would be giving to the provider. And if you've bought the insurance, then it is up to the insurance how much they pay the provider.
Pretty much, basically. So let's say provider charges $200 for whatever, routine they did. So the insurance company will be like, well, the allowable amount is really $50 or $60 or $80. So they adjust that amount, and then they pay, whatever they adjusted. So now the patient is responsible of whatever was adjusted. Okay, that's a little bit confusing. Let me change that dynamic. So let's say I am the doctor and I'm charging $200 for a service. The insurance company says, no, I'm not going to pay you those $200. I'm going to pay you $100. And then from those $100, the patient is responsible for either 30, 20% of that bill. So the insurance pays, $80, and then the patient pays $20.
The amount that the patient has to pay is pre-decided based on how much copay you have and how much deductible you have.
It's decided on the type of plan you choose, really. So a plan will have a copay, it will have a deductible, and then it will have the coverage that they will pay after everything else. So they come in, they pay their $30. Let's say they've met their $1,000 deductible. So now the insurance will cover those 80% of the charge, and you're only left with that 20% of the charge.
Melissa, just going back to your example before, that means the service that was worth $200 became worth $110 or something like that?
Correct. So the insurance will adjust based on their allowable charge.
Okay, so it doesn't really matter what you wanted to charge in the end.
Yeah. Basically, you can charge whatever you want. The adjustment is just going to get bigger,
Yeah.
So let's say instead of charging $200, you're going to charge $400. They're just going to adjust it to a larger amount.
Back. Okay.
Yeah.
So when a doctor is deciding which insurance company they want to work with, that's when they'll see how much they adjust for, because that's what would affect the practice.
Exactly. They will give you the allowable amount for every CPT code that you will bill. They have a list of all the CPT codes. So it's your homework to make sure that you check and see how much the allowable charge is and how much you will make based on what you're charging. So again, the provider decides, do I want to really join this insurance company? Is it beneficial to me in my practice?
So that's the reason why certain physicians don't accept some Medicaid or Medicare.
Exactly.
Since the PORA costs may be lower than certain other insurance companies.
Correct. Yes. That's why a lot of physicians are going to cash base.
Mm-hmm. Also, it's a tug of war. The insurance company will negotiate with a hospital, for example, and if there's no other hospitals around, they may have to pay more. So that they negotiate.
You are able to negotiate. So each company is different, and they will give you the lowest cost, but you're able to call and speak to someone and try to negotiate a higher cost.
But all that takes a lot of time and staff. That's the problem. And money.
So I'm just going to
Yeah,
go,
please.
Dr. Stein. So I was thinking hypothetical. Would it be then better just to accept everyone and every insurance, or does that not work? Because then you have a wider base of patients.
Well, I mean, that's really up to, the physician, if they're willing to work with all the different companies, including cash.
That
you know?
makes
Yeah,
got it.
that is
But
completely
that
up to
creates
you.
time.
Yeah, exactly. Because you have to go in and talk to each insurance company and try to negotiate your fee. And maybe if you lose in one insurance, you will gain in the other because they're all different. For example, United Healthcare, they've adjusted a lot of CPT codes. So we're losing in United Healthcare, but we may be gaining more in Blue Cross Blue Shield because they pay more. So it's
Right.
really a balance that you would have to see if it will work or not, if it will pay your bills and your overhead.
This is what it's really like.
Yeah.
It's hard. We still do not have universal health care. We talk about a single payer program. We don't have that. It's political. It's just may not happen.
But I think discussing it in this forum really helps bring a lot of clarity to how what the reality is. So,
For you, it's clear. For us, it's a mess.
yeah, I mean, a more clarity into the mess, I guess.
Yeah.
If that's a better way of putting it.
Also, the hospitals are buying doctors' practices. They're sort of buying the patients in the practice. So Dr. Bernard has like 70,000 patients in his practice. If they would buy his practice, they would buy the patients, and hopefully that would be, worth having that list of patients to come to their program. It's very hard sometimes to practice by yourself, or groups are selling out to hospitals.
And the very smart thing that Dr. Bernard has accomplished is that not only is he, a physician nowadays cannot live out of just office visits. They just can't, because the reimbursement is so low. So you need to do testing. You need to buy equipment and do your own testing, and that generates more income. So Dr. Bernard not only sees, new patients and follow-ups, the general evaluation, but he has them do the EEGs. Instead of going to the hospital to do it, you do it in your practice. The carotid Doppler, instead of sending them to the hospital, you do it. The sleep study, instead of sending them directly to a sleep center, you do it. So all of these different testing that a lot of doctors refer out to, he's doing it himself in his practice. And these tests are a lot more than just a regular follow-up or a new patient visit. So that's where most of the income is coming from, is from these type of tests. But then again, to get them approved, you got to make sure that your notes go along with what you're requesting. And you got to make sure that your staff is getting a prior authorization prior to the patient coming in to do the test. And then you have more income coming in to cover everything else. But first you have to invest on all these equipments that are not cheap,
It's kind of like in-house ancillary tests. So you get those add-on costs, which these patients would have to shell out somewhere else, but they would come to Dr. Bernard, since quite a few equipment would be in-house.
Correct.
And if I
Are you
understood,
sure you want to come to America? What are you going to say?
I just wanted to clarify, if I understood correctly, the fee is always different because it's always negotiated between the hospital and the insurance company. So it's always dependent on that negotiation, right?
Yes, in terms of the
much.
hospital, yeah, right.
Okay.
Just going back to something that was discussed earlier. So in order to cover all your patients, that is patients who cannot afford like fancy insurances, or those who have cheaper insurances maybe. So one way to do that would be to, like the example you gave was there was a Blue Cross and there was another insurance company, and one of them maybe pays you more for your services and the other pays you less. So if you can somehow balance that out, then maybe you could take care of everyone. Is that how that would work?
Exactly. So, you know, if you are that type of person that want to help everybody, even the ones that can't afford it, you know, you got to make sure that you do get in contract with an insurance company. For example, private insurance companies that are given by the employers pay more than you know, a Medicaid or a community plan. So you will submit your payment and they will pay you a lot more than one of these community plans will pay you. So it kind of balances it out. Because there are plans that are very well. For example, Blue Cross Blue Shield government, what's it called? Blue Cross Blue Shield federal, that's what it's called.
Right.
They pay very well. They pay very well compared to, you know, privately, or an insurance that you get on yourself instead of an employer. You know what I mean? Or the community plans that the state offers for those that have low income. They could be a Blue Cross Blue Shield, but it's a different plan. So you got to be aware that not all insurance companies have the same plan. They have different type of plans depending on the income of each person.
And when you come here, you will probably have to buy your own insurance, business insurance or something like that. And it turns out that it's only good for emergencies. It's not good for regular care. So we had a patient one time who had problems with sleep and wanted to get a sleep study. And she was a visitor in the States and had this visitor's insurance, and they wouldn't pay for it. You know, so you need to be aware of what kind of insurance you get when you come here. We couldn't make the case it was an emergency, so she paid cash.
Is it usually the companies like Blue Cross Blue Shield that pay more to the provider that also cost the patients more? Is that how it works, or it's not dependent on how much the patient pays?
It definitely depends on what the patient pays. So the more the patient pays, the more benefits they have.
Mm-hmm. There's a statement called "follow the money," basically. It's all money. It's all money. It has to be, because insurance companies have to have enough money to pay. And you know, we have more and more technology, which is very expensive. Genetic testing, for example, costs a lot of money, and we want it to happen, but I mean, there's an economic issue we have to face up to. Old people get all the care. All the money on Medicare is, the last year of life is so expensive. And there really is not enough money to go around. If you look in the future, people are very worried about whether or not we can provide the care for everybody as time goes on. There'll be a lot more old people. Old people need a lot of medications and stuff, and old people living longer. Used to be, usually people would die like at 55, 60. So now they're living to 100. And all that time, they need medical care. It's expensive. So there are people who say maybe after 75, you don't get any more care.
And that's when you need it the most.
Yep.
When you're older.
I was just gonna say I object greatly.
Mm-hmm.
Everybody should have care while they're there, while they're living life.
Well,
I don't know, it might sound idealistic, but
no, it's based on a philosophy
that
everyone deserves care. But that's only one way of looking at it. It's not a privilege. You work hard, you earn money, you pay for your care. You don't have no money, you don't work hard, tough shit, basically. That's more of a Republican point of view. We've never been able to get Congress to agree that everyone is entitled to health care. We tried very hard for over 100 years. It won't work yet.
Is that what you believe, Dr. Stein?
What is that? Of course,
Is that what you believe?
Yeah, I do. Of course, I think everyone should have health care. I think
Yeah.
it makes a healthier country. If you have all these people who are disabled and can't get health care, they're not working and not providing for services to our country. So yeah, I think a healthy. If you're running an army or military group, you want to make sure all your soldiers are healthy, right?
Yeah.
We are all soldiers in this country, and we all should be healthy. But that's my philosophy. It's not the way the government runs. And in this country, like Medicaid, for example, which is for poor people, the government has offered a much more expansive Medicaid to each state. And some states say, no, we don't want it.
Mm.
And that means that they're deciding their citizens will not get the kind of care, better care. It's a political issue.
What I don't really understand, I mean, from a morally point of view, from an ethical point of view, it's the case entirely clear, right? But even if you look at it from a economic point of view, it would be, I mean, it would make sense to invest in preventive care, for example, in a diabetes patient to make sure he goes to his checkup regularly, that he takes his medication, because in the end that would even save money, because he wouldn't need to get an amputation, for example. So I don't really understand why. I mean, it would make sense, right?
Well, the person you have to convince our legislators, a congressperson or a senator, to vote that way. But that person is pulled in many different directions. Also gets lots of money from special interest groups who have their own concern. And so the ethical moral issue is in the background.
Mm-hmm.
But how does that happen, Dr. Stein? How can you just put aside those things? And is it really the bottom line? Like
America was never never generally cared for everyone's health. We are a country of opportunity. We do our own thing. We make profits from it. And in our moral sense, taking care of everybody was not an issue. It was not our way of thinking about things. It's not.
Do you think it could be brought in?
Well, we keep trying to do it, but there's a lot of people who really think that it doesn't make sense. They don't deserve it. A lot of racial issues in this country, where people of color get much poorer care than people who are white. People of color don't have their pain recognized as much as white patients. It's complicated. And we, our country is so split with different ideas, but liberals obviously want health care for everyone, but the conservatives don't think that makes sense. And meanwhile, people die. I think I said earlier that there could be two towns 20 miles apart, and one town lives 20 years longer, the other one doesn't. I mean, it's
There's no zip code. That's what they were saying in the video. Like even between zip codes, you could have that difference.
Yeah, exactly. So we don't have the same social conscience that you have. We don't. When I say we, that is, there are not enough people to vote in that direction.
I think that's more of a thing.
Mm-hmm.
I think that's more. But I think there is a social there must be a social conscience.
A
But
social,
just voting, I think there must be a social conscience.
yes, you can
But-
think that, but make it happen.
Yeah, that's it.
Mhm.
There's not enough people who are putting words into action, I guess.
Well, you have to study countries and get a sense of what the ethos is, what they believe in and what they practice. I mean, this country, you know, the discrimination that happened in this country still happens. That's not a social conscience. It's just, it's the way people are, the way people and treat other people, and that's it. I mean, how do you change a country?
There's no answer.
Hmm?
Takes time or generation.
Hmm.
And that's even if they want to change.
There was a book by Alexander de Tocqueville, very famous book. He came to the States for 2 or 3 years and wrote about the American, what America was all about. It was like in 100 years ago, but nothing has changed. I mean, we are freewheeling. We are not necessarily groupies. We do our own thing. We had a country that was empty, although we created a genocide, but it was all individual. Everything was individual conquest, individual success. It was not and that's our history of the country. And so if you are successful, you work hard, you do your own thing, you get healthcare. But people who don't do that are bad people.
I mean, I see the individualistic thing as a good thing because out of that comes innovation and progress,
Yeah.
which is what a lot of people are looking for in their opportunity. Like this is the opportunity that we have. But then the downside is that a lot of people fall through the cracks. Again.
Right. And we try to fix that with Medicare and Medicaid. But when you have states, for example, I think the government says if you cover everyone with Medicaid, we will pay the first 6 years, we'll pay 100%. After that, we'll pay 90%. Okay. And that and states say no, we don't want to do it. So there's no social conscience at all when a state says we won't take your money. We have crazy issues here. We have governor of Florida that initially he said that a lot of cruise ships come from Florida. And he said that anybody who refuses to accept a passenger because he's not vaccinated, you have to pay $5,000 in a fine. I mean, you know, we have people, you know, you can't wear a mask. You know, we have, we're very crazy situations. People do their own thing. There's no social conscience. Now, Massachusetts, everyone's insured. That state managed to put together a situation where everyone's covered. I think in Texas, only, you know, one third is not covered. And if you're an OBGYN person, you really have to be careful where you practice. Because right now in one state, I think there's a law coming up that if you do an abortion, you may get 15 years in jail. And now the issue is that a lot of states are essentially saying no abortions at all, even for rape or incest, which is crazy. We're going back to the old days. And in Texas, they say that any citizen can arrest a person if they're involved in an abortion. I think in some cases, I recently read you can't even offer an abortion to people. Many rules are that you have to hear the heartbeat, you know, and the patient has to hear the heartbeat before they decide about an abortion. These are all the interferences in medicine. And most recently, you know, you could get the pill for an abortion. And Texas is now trying to find a way to punish you if you get the pill, even by mail. We also got this issue of conscience. So if you want the day after pill, you've had intercourse and you're not sure, a drugstore can decide not to give it to you because of their conscience.
Yeah, I
Yeah.
heard of it.
Yeah. So this is our strength and our weakness. Unlike other countries, we are, we don't all march to the same step. You do the best you can. If you can't afford to see a poor patient, you won't do that. I think Dr. Burnett probably should not see as many patients who don't pay. I'm not sure how you feel about that, Melissa, but if he has more patients who are paying, he can pay you more money, increase your salary.
Yes, he is very generous. He has even, patients have switched their insurance and we're no longer in network, he will still see them. So
Mhm.
that's, a loss in his pocket,
Yep,
but he's still willing to see them.
that's very unusual, really. Most practices have a front office that decides who can come in and who cannot come in.
But then again, there are those patients that want to take advantage of your will and your goodness, and they will,
Mhm.
So you as a provider have to be very careful who you're willing to help and who you're not willing to help.
In
And
that
then
case, I
again, you
think
have to, make enough money to sustain your practice and pay your employees, because then you're out of business. So you can't help everybody.
And people do fall between the cracks.
Mhm.
And some people die much earlier than others because of not getting poor care. And we accept it in this country. No one seems to be insisting that we make changes.
and just with regards to patients taking advantage, like I have another story to share. Like a patient I saw recently, she came in with the most beautiful story of like having very deep depression and issues with concentration, and she had never been diagnosed with ADHD as a kid as a child because of her cultural issues and parents reluctant to seek help because she was from an immigrant background. So she was never, so she had a lot of concentration issues. So she said she saw a psychiatrist or psychologist as an adult and was prescribed Adderall, and it really helped her. And she was able to gain a job despite not doing well at school. And then she ran out of her medication, and she presented to our practice, saying that I've lost my job. I haven't had my Adderall for a month, and I've lost my job 2 weeks into it because I didn't have any concentration. And I was listening to her story, and I was very moved. She also was talking about her depression, and then she said she didn't have medications for that either because her practice shut down and all of that, and she couldn't get her medication. So I went to my provider, and I presented the case, and he was able to access all her previous medication history and any medication she'd ever been prescribed. There had never been any Adderall given to her at all. She'd never been prescribed Adderall. And he said to me that this is just something you have to learn, that you're going to see people like that, and you're going to have to learn from these things that not people will try to take advantage. And that was just one of those things. I could not have predicted it if it was.
Mhm. In Virginia, every prescription that is considered possibly abusive, like narcotics and stimulants, is reported to the state database. Okay, and so when Dr. Van seeing a patient, he can pull up the entire history of those patients Medicaid, where they got them, what time they got them, which pharmacy, to see whether or not people are compliant or whether they're cheating, basically. We've done that because of the opioid problems in this country. People dying all the time.
And you'll be surprised how many of your patients will lie directly to your face and say, I have never gotten this prescription anywhere else. Yet when you go in and you pull out the records, about 15 days ago or a month ago, they went to a different provider to get the medication, or they went to the emergency room to get the medication, you know?
That was the case. She'd never been prescribed Adderall ever. And he said to me, he's like, I like seeing young doctors being put in this situation because that's how you learn. Because I was almost sobbing with her. I was so taken into the story. And I felt foolish, but I can't lose my humanity, I guess, just over that one patient. I don't know.
I had a very similar story too. This was in India though. In my psych rotation, there was a patient who came in who told me that his son had been in an accident and he needed to leave the hospital. And I was like coordinating with everyone how to arrange his transport, how to get him out of the hospital, so that he could go help his son. And it turned out, and I knew that he was admitted for like alcohol de-addiction, but it never crossed my mind that he was trying to leave the facility for that reason. And then later on, the nurse actually told me that this was a recurrent pattern and that he had done this before as well. And I actually got his wife's number. I called her to check with her whether the son was okay, etc. And it turned out he was in some other town. He was completely fine. And this was just something that he was telling me to get out of the hospital. But it was so convincing. I thought like he was in such a bad situation and I thought like I need to help him.
A lot of patients will even come in and say, my prescriptions were stolen. I left them in the car, someone took them, or I dropped them down the drain, or some weird, even convincing stories. So what we do in the practice is that we ask for a police report. Go give a police report, because at least we are backing ourselves. Because if, let's say, this patient gets an overdose because they have their prescription and we gave them another 30-day prescription, it will be on the provider. So you have to cover yourself. So we tell them, go get a police report so we can have something to back it up.
Sometimes you have a contract with the patient, which probably isn't worth anything, but your patient agrees to the terms. One of the terms often is that if you lose the medication, it's tough. You'll have to, we're not going to fill extra prescriptions for codeine or morphine, something like that. And I got sucked in one time. I just felt so badly. The patient had somehow missed her medication, ran out of medication early, and she was hurting a lot. And I just felt my heart went out to her. And I got stuck. I used to feel that pain doctors were very cruel because they didn't make any exceptions. But these days, I think you have to, it's full patient responsibility. As Melissa said, we can be fooled, write another prescription, something happens to the patient. Yeah.
That's what my provider was saying. He's like, you'll prescribe the Adderall, and then in a month's time, they're going to come back and they're going to say, oh, doctor, I was waiting to see a psychiatrist and I just couldn't get in. And can I just have a little extra to tide me over? So you'll give a little extra and then it'll just keep going and going and going. And they'll never see you.
These patients are very convincing, extremely convincing. And they will talk and talk and talk to where you want to just get rid of them. And then you'll just write that prescription. But you have to be really, we had a nurse practitioner and the patients would just talk her brains out, and she was like, oh my God, I can't, you know? So sometimes she would write those extra prescriptions, you know? So you also have to have a hard demeanor and say no.
Mm.
Yeah,
And that's what the provider, sorry, go Dr. Stein.
what's happening is that this nurse practitioner retired, and Dr. Manad seeing all of her patients, and it turns out that her prescription of narcotics was much higher than Dr. Manad's. And so all these patients, we had to say, we can't give you that dose, and they're crying and screaming at us. So it's been a real problem because they all come in with too much, as Mill says, too much narcotics.
And they will try to fool you.
Yep.
Yet they don't know that Dr. Bernard cannot be fooled. And a lot of them are not happy and they will leave. But then a lot of them will know that they can't get it anywhere else and they will stay. And they will cry and cry and cry, but it's up to you to say no.
The Board of Medicine, I think, suggests that anything under all narcotics can be computed under called morphine equivalence. And basically anything over 90 morphine equivalents raises eyebrows. And very often doctors are afraid to go higher, even if the patient needs that, because they don't want to get involved with the state. But very recently, there's a proposal by the CDC that suggests that doctors could be freer to just treat what the patient seems to need, and don't worry as much about the limits on equivalence. They're saying that's not fair for patients. So you have people, so if you really think the patient needs more medication, I think you may be able to do it more safely without getting bothered by the state. And we're in a real crisis. And for many patients, the rules are too tight. And unfortunately, civilians, not doctors, make them some of the rules for how doctors can practice. I think I mentioned earlier the law in Florida, which said you cannot ask a family if there's a gun in the family. You cannot ask that. And it was a law. I mean, the civilians said doctors shouldn't ask about guns in the house. It's telling you how to practice medicine with penalties.
And I just figured out that is something else that we've got to consider as IMGs about all these laws and what we can ask and what we can't ask. How do we find out? Like, if I'd been in Florida, I don't know that I couldn't ask about guns.
That's changed, but it's obviously very well.
But could be anything else.
Yeah.
Like all these unwritten laws that would be obviously different for every state. So are these mentioned or informed to the new batch of residents, or is it something we learn as we see patients? Because some things which might be able to get us sued, if we don't know it in advance, we might not ask. So are these taught to us early on during our intern years, or is it something we just have to pick up as you practice?
I'm having trouble understanding you with your accent. It's my problem, but sometimes I don't understand exactly what you're saying, and I feel bad about it, but it would be helpful for you to get an assessment to see if there's some changes you can make. I mean, I want to hear you, but my head doesn't process what you're saying. I don't know the question.
So what I was saying is that all these unwritten laws, as I mentioned,
Yes.
not being able to ask about a gun in the family. So are these things certain laws specific to certain states, So are they taught to interns or new residents early on, or is it something we'll have to learn on our own as we see patients?
Well, a law like that would be very clear. You know, it's crazy enough that people would talk about it.
Right.
There are, you know, that's, well, but let us say that the state of Idaho, I think, is deciding that you can have no abortions. Okay, you'll know about that. In the state of Colorado is making it easy to get abortions. But the penalties for doctors are very high. And all of that is done by civilians, not by doctors. And you have to put up with that. And that's, you know, that's how it works.
I feel like a big part of the problem in every country actually is that politicians get way too involved in questions of healthcare, and they're not turning to doctors and experts for reasonable answers. They just decide based on their interests, which are not medicine, but you know, their interests, political, economical interests.
Or the interests of religion.
Yeah.
Yeah.
I read that in Texas, as you said, like even people who help in the process can get charged. For example, if someone were to take an Uber to the abortion clinic, the Uber driver can get charged.
Yeah, crazy. Yeah. You know, obviously, you adjust the rules when you're practicing. And just as Dr. Bernard says to some patients, I can't give you the medicine you want. I can't do it. The government has said I can't do it. Or the government says I cannot do an abortion. I can't do it. There's the, you know, those are the limits. But, you know, a medical license is given by the community. The Board of Medicine represents the state of Virginia, for example. And they give you permission to practice, but under their rules. Which makes sense in many ways. And each state can be state. For example, if your patient has epilepsy in California, you have to report it to the government. That's the rule. If your patient has epilepsy in Virginia, you do not have to report it to the government. You can decide in Virginia whether or not you want to report it to the government or not. You can decide whether the patient can drive or not drive. I mean, medical rules sort of 3 months, no seizures, 6 months, no seizures, sometimes a year, no seizures, but that's a medical decision. In California, it's not a medical decision. Every person with a seizure has to be reported or you get penalized.
So wouldn't it be just better if there's like a standardized list of things that could be reported by the board instead of having it being different in each state and changing it, you know, something that's common for the entire country?
Our Constitution says that all things that are not directed to be done by the government are free for the states to do. It's called states' rights. And we have essentially, conceptually, 50 different countries in our country. We all come to different rules. And that we are the United States, not united, we are the United States. There's crazy talk of California deciding to secede from the Union, just become an own country. I mean, it won't happen, but those ideas exist. So states' rights are very important. And, you know, we had a civil war, the North against the South. 500,000 people died because one state wanted to succeed from the Union. And the issue really was about slavery. And states that the southern states wanted to keep slavery, the northern states didn't. But you know, it's that you can see that each state makes their own rules. And doctors have to go along with those rules, or else the state gives you a privilege to practice in that state with their rules. You're right, it should be universal. It's not. Taxes are universal to pay the government, but state taxes are different. Each state can decide. For example, right now with the gas prices, all states usually have a gasoline tax. Some states have decided to give it to not get the gasoline tax so people can get cheaper gas, but it's a decision on each state. I give you a very funny one. You know, we all go to the gas station, fill up our tanks ourselves, right? New Jersey has a rule, you cannot fill up your car, a person has to do it for you. It's a rule.
Oh, yes. Yes.
Okay? Yeah.
I saw that.
Okay, and that's the rule. Because that state decides what the rule is. Same thing with medicine. They decide what the rules are for medicine. That's our system. We're stuck with it. And we try to work around it. But this is America.
If enough like-minded people got together in a particular state, they would vote the people to the, I don't fully understand the political system in the United States, but if you vote for the people who have a similar ideology, then that would be the state law then. Is it called the Senate?
If you work, I'm not sure I understand.
You vote people to power and then they decide what the law would be. So in a state, what would be the, I'm not sure what the level would be. Like you have a central government and you have a state government. In India, you have state governments and you have a central government. And then each state votes for a particular government and then they decide what the law would be.
Right.
So as well, is it similar to that?
Yeah. If you're a very liberal state like Massachusetts, everyone has to be insured. If you're a religious place, kind of state, well, no, people should not have abortions because life is more important than abortions, even though they don't, there's no care for the child is not wanted. There's no care for the child, but the religious position is that it's morally more correct to have no abortions, even if your young girl is pregnant by your father. And that could be the rule. Because those people have a right to decide that.
I guess what I'm asking is who gets to decide? I'm not understanding, because if it's all the people get together and then they vote for somebody who will bring that law into action. So it must be a collective decision of the people that they decide that it's not moral to allow abortion wherever.
Well, what happens realistically is people get elected and then make their own decisions. I mean, they are supposed to represent us, but I think, often it doesn't look like they're representing our interests.
It's mainly the governor of each state that, pushes the law. So the citizens do vote for who is in charge of their state. And depending on their political views, or religious views, they set their laws for the state.
Some states say you do not have to wear a mask. Other states say you have to wear a mask. There's a big issue about parent rights. And parents say, I have the right to decide whether I want to get my kid wear a mask or not. And, so people who have children with immunocompromised situations, they say they have to wear masks. But our governor of Virginia just got reelected. He said no masks. In education right now, what's happening, it's crazy. A lot of states, we have a thing called critical race theory, I think it is. And at this point in time, the liberals want to teach kids about the effect of segregation on the population and how Black people have been very poorly treated and have had a very bad outcome. So they had a sense of what our history is. And many states say, no, you can't do that. Teachers are not allowed, for example, teachers are not allowed to talk about gender issues up to the third grade in some situations. You know, so teachers have the same kind of problems doctors have. And during the confirmation hearings for this Judge Jackson, who's the first Black woman, hopefully to go on the Supreme Court, she was involved with a school that was very liberal, and they actually were complaining about the school was too liberal, and these courses on gender, which my daughter invented. She was very famous because all the conservatives were essentially, they were attacking her policies in that school. The school that we belonged to, called Georgetown Day School, was put together by a bunch of Jewish families and Black families before Brown versus, before the law was that everybody was entitled to the same education. And so that school has a long tradition of dealing with racism and things like that, and teaching about racism. But their politicians say that's not right, we don't want you to do that, and they can tell teachers you can't do it. So we're very proud that we were in the press and do articles about the school talking about my daughter's program. But these, you know, these are the controversies in society, and it's not, nothing's new. Every country has, you know, the left, the right, the reds, the left side, the right side, you know, the freedom side, the environmental party, and we just keep playing the game and working on it. There's no script. Every day we invent what we're going to do. And welcome, you know, welcome to America. At least you can fight in America. You can express your views. Dr. Bernard and I have had totally opposite views of politics. Totally. And we get along very well.
Actually, I think for me, that is one of the best parts in America, that you can get along even with that kind of opposite views and opinions. And I feel like that kind of notion is very strong in the United States.
Mm-hmm. It is, yeah. It's amazing how different I was with like, Melissa, have you heard of some of the things we talk about?
Yes.
Yeah. Dr. Bernard left Hungary with his family during the communists came over. The family immigrated to South Africa for a while, then immigrated to Canada where he trained, and then came to the States. He is a very, very strong person for individual freedom, individual rights. That, for example, telling people they have to get the vaccine is not in his ballpark. He would say it's up to the person. So my position is more about social responsibility, that we should make everybody do the right thing. His position is very clear that no, freedom is more important. Freedom of choice is more important than, for example, getting the vaccine, whether you like it or not. These are very different views.
I find it interesting, now that you mentioned it, that sounds very much like my dad's story. He also immigrated from Hungary for the same reasons, communism. And he grew up with the same values, so individual freedom. So that's very interesting. That, I mean, it's clear that the background influences what your values are, how you express and form your opinion.
Mm-hmm.
That's very interesting.
And it comes out in how you practice. How much do you ask your patients to get the vaccine? Do you recommend it? Dr. Bernard sometimes, well, it's just another virus. You know, and we fight over those things, and it's fun.
Yeah, but I feel like it's, I mean, especially interesting to talk to people, to have discussions with people who have a different opinion. I mean, I don't need to talk to people who have the exact same opinion as I do, because I would learn nothing new. And if you talk to people who have a different opinion, then you can learn something, get a different kind of point of view. So I feel like that's the best part, actually.
Well, that's the best part of America.
Yeah.
It's the hardest part of America. Because we really haven't solved the racial issues at all. You know, we really have not done that. We haven't solved the issue of a woman's right to choose versus sanctity of life is very important. They're both interesting arguments. I mean, you can get to a point where you believe the sanctity of life. What did Dr. Nance say in that videotape? He doesn't want to kill a fly because they have a nervous system, okay? I kill flies, I don't care, I kill flies, okay? But so when there's issue of abortion, I understand completely the sanctity of life, how special it is. On the other hand, if my daughter got pregnant, I want to get an abortion. And so these are big values we're struggling right now. And that case is in the Supreme Court right now, whether or not women have the right to deal with their bodies. One hand says the body belongs to the state. Your uterus belongs to the state, and we'll tell you how you can use it. The position is your body. This is a real issue in America, and it's surprising. People, very Catholic countries like Spain, no problems getting abortions. In our country, so many people feel the other way.
I feel that if they follow the system of, as you mentioned, the uterus belongs to the state, I think then in that scenario, the state should also take upon the responsibility to educate this child. The funding should be from the state per child. If you are in that view of the uterus belongs to the state, so in that case, you're taking the right away from the parent to decide.
Right.
Because if you follow something, you should follow it through, not just partially, where you decide what happens to a child, but when child is born, you don't take care of the child. So it should be both ways.
You make a lot of sense, but the problem is, how do you make it happen? Okay, that's we have a lot of great ideas. We're very ethical, very moral, but how do you make it happen? It's very complicated. You have people on the other side who don't agree with you. And if they have the power to vote, you lose. This is not a consensus society. This is a voting society. For example, I think Medicare won by one vote. Social Security by one vote, okay? Judge Jackson, usually Supreme Court justices get many senators supporting them. I think she'll get in with 2 or 3 votes only, over 50. It's and that's how it works. Winner take all. Our legal system is adversary. Each side fights the other side. Okay. Consensus would be much better. The consensus would be we all agree. We can live with it. We don't like it, but we can live with it. But our country is very different. As are other countries. I think in Israel, one man left the party, now it's a 50-50, and they're afraid they can't pass any laws. But even in our country, for example, if in Congress, the 50-50 vote, the vice president can come in and make the vote on the other side. But things get in by very thin margins. So we live with that, and you come here, you live with that, and you make the best you can. You can't take care of everybody. Society needs a lot of changes. Do what you can, or often you move to a place where you agree with the policies.
So when you choose where you want to apply, be aware of their policies and what party they're in, because if it's a red state, it will go more towards, their laws. If it's a blue state, it'll go more towards the other laws. So be aware of that.
If you're an OBGYN person, you don't want to go to Texas. You want to go to Colorado. They're opening the doors. So we're not exactly united. We're the almost United States. Almost united. We're not completely united.
That's right.
The only thing that unites us is a war or 9/11 that united us for a while. So come here, make trouble, have fun, express your views, and join all of us. It's this is our life. Washington, D.C. is not a state, okay? It's a district of Columbia. And therefore, Congress can decide what our rules are. Okay? Congress can decide that we're the only part of America with no representation. We have a few members that go to Congress, but they have no power. And so we're stuck. If we want to sell marijuana, the Congress says, no, we can't do it. We have no input into various policies the government wants to make because our representatives don't have often the power to make that vote. There's things they can vote on and things they cannot vote on. No, so we live with those kind of rules. Okay, I have to leave at 1 o'clock. You want to keep continuing, Melissa?
So I think we can start up tomorrow.
Okay, great. See you tomorrow. Okay.
Okay, thank you. See you
Thank
tomorrow.
you, sir.
Have a good day.
Thank you.
Okay.
See you
Bye.
tomorrow.